Good morning, ladies and gentlemen. My name is Dita Iriati Rukmana, and I'm so honored and glad to be here. Also, it's wonderful and it's precious for me to be your master of ceremony in this virtual conference on Tuesday, 4 November 2025, in our big event, the 5th East Borneo Health International Conference and the 5th International Conference Lactation Management. In this beautiful moment, I would like to welcome all the participants in virtual conference by Zoom meeting and live streaming and our YouTube channel. And we would like to greet our incredible speakers. It is truly an honor to have you here. The Honorable Director of Health Poltekkes of East Kalimantan, Dr. Nurse Parelangi, Magister of Nursing, along with all staff, our distinguished respected speakers in this virtual conference, Professor Dayan Alspas, PhD from USA, Sri Devi Mutu from Malaysia, Devi Syahrul Ramadan, PhD from Thailand, Dr. Nurse Tini, Master of Nursing, and Dr. Evi Nurrahma, Master of Health from Indonesia. And our distinguished and esteemed participants, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. All praise and gratitude belongs to Allah Subhanahu wa Ta'ala, who has been giving us guidance, happiness, and healthiness to hold our 5th East Borneo Health International Conference and the 5th International Conference Lactation Management. The theme of today's international conference is Digital Transformation for Global Health. All the participants can join this conference by Zoom meeting and live on YouTube streaming. And this webinar is organized by Health Poltekkes of East Kalimantan. Ladies and gentlemen, let's begin our webinar by reciting Basmalah. The audiences, please stand up. Singing the national anthem, Indonesia Raya, and the march of the Ministry of Health Poltekkes. Audience, please be seated. In order to have our webinar run conducively, let us invite Mr. Biondi to lead us in prayer. To Mr. Biondi, time is yours.
Ladies and gentlemen, let us take a moment of reflection according to our own beliefs. Please allow me to lead this moment in a universal and inclusive manner. Dear God, we gather here today with grateful hearts, united in the spirit of learning, collaboration, and innovation. As we begin this meaningful program, we humbly ask for guidance and blessing upon our shared efforts. We pray for the success of the EBHIC implementation of digital technology in diabetes management. May this initiative bring clearer insight, stronger evidence, and impactful solutions that improve the lives of individuals living with diabetes around the world. We also lift up the ICLM's focus on innovation in lactation management. May this effort support mothers and children everywhere, promoting global health and nurturing future generations. May every discussion, idea, and partnership formed today bring positive change and meaningful progress for communities globally. Bless this event, bless every participant, and guide us toward outcomes that honor humanity and reflect compassion, knowledge, and unity. Amen.
Thank you to Mr. Biondi. And next, report of the head of committee. Please welcome Mr. Rizky Setiadi. Time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning and prosperous greetings to all of us. The Honorable Director of Poltekkes Kemenkes Kalimantan Timur or his representative, our highly valued speakers and presenters from across the globe, distinguished guest lecturers, health practitioners, and dear participants. On behalf of the International Conference Committee, it is a profound honor and pleasure to welcome all participants to the joint event, the 5th International Conference on Lactation Management and 5th East Borneo Health International Conference, held right here at Poltekkes Kemenkes Kalimantan Timur. Our theme, Digital Transformation for Global Health, is not just a topic, but a call to action. It reflects our collective goal to enhance health services through the power of digital information technology. Ladies and gentlemen, the heart of an international conference lies in the expertise and wisdom shared by its presenters. Today, we are exceptionally privileged to host an array of brilliant minds. Allow me to extend our deepest gratitude to our esteemed speakers. Professor Diane L. Spatz, PhD from University of Pennsylvania and Children's Hospital of Philadelphia, United States of America. Ms. Sri Devi Mutu, SRN SCM, from Management and Science University, Malaysia. Mr. Debi Shahrul Ramadan, PhD, IDF Senior Fellow from Chulalongkorn University, Thailand. Dr. Nurstini, Magister of Nursing, and Dr. Evin Nurrahma, Magister of Health from Poltekkes Kemenkes Kalimantan Timur, Indonesia. Your willingness to share your invaluable research and practical insights is what truly elevates this conference to a global stage. The knowledge you bring will not only enrich the discussions here, but will directly impact the competence of our practitioners, educators, and the future of digital healthcare in our region. Thank you for making the time and effort to contribute your expertise to our participants. I would also like to acknowledge the hard work of the organizing committee and all of the sponsors. Though we face the challenge of limited preparation time, your dedication ensured that we could successfully execute this major event on time today, November 4, 2025. I report that today's participants reached almost 2,000 registrants who are students, lecturers, health practitioners, and health observers from countries around the world, such as Indonesia, Malaysia, Turkey, and Scotland, United Kingdom. To all our participants, your presence is the driving force of this conference. I encourage you to seize this opportunity to connect, question, and collaborate. The Honorable Director of the East Kalimantan Ministry of Health Polytechnic, represented by Vice Director 1, Mr. Dr. Ratanto, Magister of Nursing, it will be an honor for us if you would be willing to deliver a speech and officially open this International Health Conference. And may this conference be a fruitful platform for learning and innovation, taking us one step closer to realizing excellent, digitally transformed health services. Thank you once again. I wish you all a successful and inspiring conference. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Mr. Rizky Setiadi. And next, welcome speech from Vice Director of Health Polytechnic of East Kalimantan will be officially begin our webinar for today. To the Honorable Dr. Ratanto, Master of Nursing, please welcome and time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Our distinguished keynote speakers, Diony L. Spatz, PhD, RN, BC, FAWHO, NN, FAAN from United States of America, Sri Devi Mutu, SRN, SGM from Malaysia, Debbie Sahru Ramadan, PhD, IDF Senior Fellow from Thailand, Dr. Nastini, Master of Nursing, and Dr. Evi Nurrahma, Magister of Health from Indonesia. Respected college partner from universities and institutions, and dear participants. Good morning and welcome to the International Seminar on Digital Transformation for Global Health. On behalf of Poltekkes Kemenkes Kalimantan Timur, it is my great honor and privilege to extend our warmest greetings to all of you. Your presence truly enriches this meaningful occasion. In this era of rapid digital transformation, technology continues to reshape the landscape of healthcare, improving access, efficiency, and innovation in ways once unimaginable. Yet, amidst this advancement, our mission remains clear to ensure that technology serves humanity with compassion, integrity, and equity. This seminar provides a valuable platform to exchange knowledge, ideas, and experiences that bridge technology and public health. Through collaboration and shared vision, we can strengthen global health systems and create a future where digital innovation benefits all communities, leaving no one behind. I would like to convey my sincere appreciation to all speakers, organizing committees, and participants for their dedication and hard work in making this event possible. May today's discussion inspire new insight and lasting partnership that advance the future of global health. By saying Bismillahirrahmanirrahim, with pride and thanksgiving to God Almighty, this international conference is officially open. Thank you, and I wish you all a fruitful and inspiring seminar. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ratanto, Master of Nursing, for officially begin our webinar. And with all due respect, if you have another schedule, we permit you to leave this meeting. And now to all the participants, our next agenda is presentation from our keynote speakers. But before our speaker give the presentation, I would like to say for all the participants, you have to make sure your microphone is mute and your camera is on so we can focus on our speakers. To all the participants who would like to ask a question, you are kindly requested to turn on your microphone and use the raise hand from your Zoom meeting. And the question will be answered after all of the keynote have presented the presentation. Okay, let's welcome to our moderator, Dr. Dwi Prihatin Era, Magister of Nursing. Hello, Miss Era. How are you today?
Alhamdulillah, I'm in a good health and good condition, and I hope you too, and also all of our audience today.
Okay, are you ready to lead this session?
Of course.
Okay,
Thank you, Mbak Dita.
time is yours for Mrs. Era.
Good morning, everyone. It is my genuine pleasure to welcome you to the opening session of today's conference and to introduce a pioneering force in maternal and child health, Professor Diane Spatz. Though joining us remotely from USA, Prof. Spatz's impact reaches far beyond borders. A leading researcher, educator, and also advocate, she has transformed the landscape of human milk and breastfeeding support through innovative evidence-based model. At the Children's Hospital of Philadelphia, or CHOP, she developed the groundbreaking breastfeeding resource nurse model, an empowering training program that strengthens clinical lactation support. Equally influential is her 10-step model to promote and protect human milk and breastfeeding in vulnerable infants, now adapted by hospitals across the US, India, Thailand, UK, and beyond. This framework, of course, guides clinicians and families in recognizing human milk as a medical intervention while offering skilled, compassionate support to mothers who choose to breastfeed. Her work has helped countless mothers overcome barriers and has improved outcomes for infants at risk, proving that with the right guidance, every mother can achieve her breastfeeding goals. Please join me in welcoming Professor Diane Spatz, a visionary whose passion, science, and heart continue to change lives worldwide. Hello, Professor Diane Spatz. Am I audible? tampaknya kita harus menunggu. Bapak, Ibu, dan peserta, izinkan saya menyapa dulu rekan-rekan atau audiens, para peserta dari webinar kita di pagi hari ini. Webinar ini merupakan satu kegiatan internasional yang diselenggarakan secara annual atau tahunan oleh Poltekkes Kaltim, dan kami mengundang seluruh rekan sejawat kami dari berbagai jurusan kesehatan untuk bergabung di dalam mengikuti. Setiap tahun kami selalu berganti tema yang insya Allah untuk mengcover berbagai fokus praktek pelayanan kesehatan di Indonesia dan internasional. Dan seperti biasa kami mengundang seorang pakar yang luar biasa yang memiliki kontribusi sangat besar bagi dunia keperawatan dan juga laktasi global. Beliau bernama Profesor Diane Spatz dari Amerika Serikat, dan beliau merupakan seorang pakar internasional dalam bidang laktasi dan perawatan perinatal. Sudah banyak sekali penelitian yang beliau lakukan, dan penelitian-penelitian itu mendapatkan penghargaan-penghargaan secara global, dan juga model yang berasal dari penelitian beliau yang sudah diterapkan di berbagai rumah sakit di seluruh dunia. Dan untuk di kawasan Asia Tenggara, model beliau telah diterapkan di negara Thailand. Jadi kalau melihat kesamaan karakteristik, kemungkinan kemiripan itu nanti kita saksikan bersama dan kita dengarkan dari beliau apakah model tersebut juga dapat diterapkan di Indonesia. Tentunya ini merupakan satu topik yang menarik, dan mohon maaf teman-teman, kami sedang berusaha untuk menjalin konektivitas dengan beliau, dibantu oleh tim IT yang sangat cekatan dan gesit untuk memastikan bahwa rekan-rekan audiens akan segera tersambung dengan beliau, dan kita mendengarkan bersama pemaparan beliau tentang 10 langkah, sebuah model 10 langkah yang sangat terkenal di dalam mempromosikan dan melindungi air susu ibu, ya, dan menyusui pada bayi-bayi yang rentan. Model beliau ini telah melalui penelitian yang berjenjang dan telah memberikan bukti yang tidak terbantahkan bahwa ini dapat meningkatkan frekuensi. Kami mohon maaf. Apakah kita sudah terkoneksi dengan Profesor Spatz? Nampaknya beliau sudah ada di ruang Zoom. Okay, good morning here in Samarinda is morning, Professor Spatz. Am I audible? Let us wait for another minute.
Are you able to hear me?
Please wait. And ask her to wait for while we're fixed it. Okay. Am I audible, Professor? Can you hear me now? Thank God. Okay. Let me introduce myself, Professor. My name is Era, and I will be your moderator for today. And it is my great pleasure to welcome you and audience. We are truly honored to have her with us today to share her insights and global perspective. Without further ado, let us warmly welcome Professor Diane Elspeth. Welcome, Professor. The floor is yours.
no one is going to have a long-term breastfeeding journey. So we have to be able to help people make informed feeding choices for human milk, and we have to help them to establish and sustain their milk supply. And many mothers also have to do human milk management because they're going back to work or school. Skin to skin is important for all babies, and appropriate follow-up. So this really can be applied to any dyad who is going through a lactation journey. You heard where it has been implemented. Maybe in Indonesia will be in the future. We have tables of evidence for each of those steps, published data, DVDs, and infographics. So in the US, in Tampa General, this hospital served primarily low-income or low-resource families and people of color, and their human milk rates at discharge were extremely low. They were under 30%. And so they did a quality improvement initiative to implement my model. And not only did people start pumping quicker, and not only did babies start getting more human milk, their human milk rates at discharge went up threefold. So this is remarkable. And it also meant that they had happier families and happier patients. I've worked the longest in Thailand. I've been there about 10 times in the past decade, all because of a student named Benjamin who came to study with me back in 2012. So Benjamin, she knew that they had to improve human milk in Thailand. So they worked with the Thai Breastfeeding Foundation and the Princess of Thailand to develop a nationwide strategy. So my model was translated into Thai, and we did countrywide implementation. Here's one example of just one hospital whose human milk rates at discharge significantly improved from under 45% to 70%, so a 25% increase. These are the elevator doors at Queen Sarit National Institute of Child Health. So anyone walking into the hospital is learning about my 10-step model. They're learning about informed decision making. They're learning about human milk management. So every person who walks into the hospital is getting science of lactation. In Japan, they actually started working on implementation of
Recording in progress.
Before I ever met them. I was able to go there and meet Dr. Yoshida Gunn, who is a midwife, and she was like, this is nursing practice, and it's something that nurses really need to be able to change their practices to support families. And so you can see here in a very short period of time, their human milk rates had over doubled in just 6 months. And it continued on that trajectory. My most recent country I worked with is Botswana. I went there first in 2020, right before the pandemic. When I was there, people were dying, babies were dying of sepsis and neck from a lack of human milk. So HIV really decimated their culture of breastfeeding. So in 2020, I did physician education, I did nurse education, and we developed an interdisciplinary breastfeeding committee. And then the pandemic hit, and that made things quite difficult. But now we've been able to continue to work on this project. So we introduced the computer chip pump technology, which was very important because people were using only their hands before, and people weren't able to develop and sustain a milk supply. This mom was the first mom to pump with a computer chip pump in Botswana, and you can see how happy she is. And everyone, there must have been a dozen people watching her, couldn't believe how much milk she got out in such a little amount of time. So, to present day, we now send CHOP Global Health Fellows to Botswana. They are nurses who are breastfeeding resource nurses from CHOP. Their human milk rates have gone up over threefold. They now have 6 pumping stations. They have a milk room. They have a refrigerator and a freezer, which they never had in the past in 2020. And you can see this mom here very proudly showing the milk that she is taking home. So this has been a game changer. And, we don't have babies dying every day now in Botswana. So the first step of the model is informed decision making. We know that many people don't initiate breastfeeding due to a lack of family support, a lack of educational exposure, or living in a place where it's not a breastfeeding culture. So we do have an educational DVD available that teaches people about the science of human milk and about how you can sign up for a free account. It doesn't cost any money, and anyone can use this video for patient family education. You just can't alter it. So we also have the ability to do the century model or group prenatal care. This is a midwifery model of care associated with improved outcomes. Not all of our families come to us with prenatal intent. And so through group prenatal care, people have the opportunity to learn about the science of human milk and about the physiology of lactation. So we wanted to see, did that education that they received prenatally impact both their initiation of lactation as well as their continuation? And in fact, when people participated in our group prenatal care, 100% of them initiated providing milk for their babies. And not only did they initiate, 87% were still providing human milk and breastfeeding at the time of their baby's discharge. In that lactation journey. So the dad here, he's given a list of jobs to do. We tell the mom, your job is to eat, sleep, and make milk for the baby. That's your only job. And dad, your job is to do the rest of the things. So putting the pump together, operating the pump, adjusting the vacuum, labeling the milk, dishwashing, sterilization, doing the oral care with the baby. So during the prenatal period, we also should have prenatal risk assessment be the standard of care. And so recently I worked with a group of midwives. I am not a midwife, I am a perinatal nurse by background. But we worked with an international group of midwives, including my long-term mentee, Jessica Brimley, who is the president of the American College of Nurse Midwives. And we work with midwives from Spain, France, Germany, Croatia, and New Zealand. And all of these midwives were leaders in their countries for human milk and lactation. And we developed 2 specific tools. One is a call to action about having enough milk to sustain the lactation journey. And the second is a set of clinical pathways to help you ensure that you can proactively manage people's lactation journey. So both of these articles are available open access. So that means any of you can download these articles for free for no charge. So when you look at this list here of risk factors, you can imagine that most families that you probably work with in Indonesia have one or more risk factors. Risk factors that can impact coming to volume and secretory activation are very common. Some risk factors will only have a delay in secretory activation, but others, such as glandular hypoplasia, breast surgery, chemotherapy, or radiation, will actually impact their total milk making capacity. And so, what are some things we can do in the antenatal period? In the antenatal period, we can consider antenatal milk expression. This is an integrated review, which is the highest level of evidence, where we examined antenatal milk expression and mother-infant outcomes during the first 2 weeks after birth. And we saw an improvement in self-confidence and security of having colostrum available and saved for the baby once it is born. It's very late here in Philadelphia. It's past my bedtime. So recommendations, if we were going to consider antenatal milk expression, is to start at 37 weeks gestation, so close to the due date. Do hand expression twice per day for about 5 to 10 minutes. Collect and store that milk in small oral syringes. Freeze that milk until the baby is ready to be born and have it labeled with date and time, and then alert the providers at the birth hospital that the mother will be bringing in antenatally harvested milk. Now, it's very important that people understand that if they are going to attempt to harvest colostrum while they are still pregnant, it is going to be a small amount. We would not expect them to have buckets and buckets of milk while they are pregnant, because the hormones of lactation prevent us from going into full-blown secretory activation. So we would want to give guidance that when they're doing antenatal milk expression, we should expect to be able to collect small amounts of milk, maybe 0.1 ml, maybe 0.5 mLs, maybe 2 mLs, but not a lot of milk. So once the person is going to give birth, we want to make sure that they can effectively establish and maintain a supply. So this mother here is pregnant with twins, and so when we're carrying twins, we know that we can make plenty of milk because our breasts are programmed to make more milk for their babies. Now, I've traveled, as I mentioned, pretty much all over the world, and I go lots of places and they say, oh, our parents very much value breastfeeding. Everyone wants to breastfeed their babies. And so this was Mexico, and I said, well, that's amazing. Please show me where all of that milk is stored. And you can see a little under counter refrigerator, a couple of bags of milk, and a little bit of frozen milk. And so that's clearly not enough for a 75-bed neonatal intensive care unit. People in that unit didn't have access to hospital-grade pump technology. They again had high rates of sepsis and high rates of necrotizing enterocolitis. So after birth, we want to give people appropriate guidance for colostrum. We do not expect that people make large amounts of colostrum in the beginning. We expect to have very few drops. This picture here represents a 24-hour milk production, right? Because the purpose of colostrum is not to feed a baby or grow a baby. It is meant to lay down that baby's immunobiological system. After people give birth, there's a critical window to build milk supply. So a lot of people talk about the golden hour, but it's not just the first hour after birth. It's the first 6 hours after birth. It's the first day after birth. It's the first 3 to 5 days. And if we don't effectively stimulate and empty the breast during this critical window, and if we don't come to volume by day 14, we are not going to have long-term milk production. And this day 14 volume marker, that's something we've known about now for 20 years. The original research about milk volume was published over 20 years ago. So at Children's Hospital of Philadelphia, my clinical appointment, we have over 400 computer chip pumps. I know that sounds like amazing, and you're probably all jealous about that. But when I started at Children's Hospital of Philadelphia in 2001, there was a mere 4 breast pumps for the whole institution. And it's an over 500 bed children's hospital. So in labor and delivery and in postpartum and in the neonatal intensive care unit, we have a pump at every bedside. We have people start expressing immediately because all of our babies are sick babies. None of them are healthy. We have them pump 8 or more in 24, and they all use that computer chip technology that has the initiate pattern in it. So we have worked very hard over the past, I guess over almost like 2008 to 2025. That's a long time. It's over a decade, right? To make sure that people are pumping early and often. And we track those metrics. So we actually track everything and we report it back to staff so that staff are aware of how they're doing. And this is an important metric that is missing from almost every place I go in the world. People are like, oh yeah, our babies are all breastfeeding within an hour. Oh yeah, our moms are all expressing frequently. But when you actually go and look at the data, that is not the case. And so important to have those metrics in place, important to report those metrics back to staff. So one of our barriers we identified was the ability for our cesarean birth moms to pump as quickly as our vaginal birth moms. So one of our nurses did a project to bring the computer chip pump into the operating theater so that moms were able to express milk immediately after cesarean birth in the operating theater. Now, again, monitoring that milk supply daily is very important. And these are the outcomes from our research on antenatal milk expression. And we found that antenatal milk expression did not result in earlier secretory activation, which is honestly what I expected, because remember, you can't go from secretory differentiation to secretory activation until the baby comes out, until the placenta comes out, right? You have to have those two things happen before we can go from secretory differentiation to secretory activation. Our participants pumped on an average of 7 times per day, so they were highly compliant and highly motivated, yet half of our sample had a delay in secretory activation. However, everyone did come to full volume by day 14. Why I'm sharing this with you is because we all, everyone, including those of you in Indonesia, should be tracking these metrics. Time to first pump, number of milk expressions in a 24-hour period, and daily coming to volume until the parent comes to volume. And we should be reporting these metrics back to our staff, okay? We want to use technology as our friend. So in our second publication of the International Work Group, We shared a proactive clinical pathway. So obviously, if a baby was healthy enough to breastfeed, we would always want a baby to be at the breast. But if the baby was not able to effectively breastfeed, then we would want to make sure that we get that parent pumping right away. Skin to skin is always important, all right? It's always important to help with breastfeeding, positioning, and attachment. But if we have a baby who doesn't breastfeed effectively or isn't waking up, we need to protect the milk supply. So we want to have, again, that ability to make it easy for the parent to pump. If the baby is well enough to go to the breast, we want that baby breastfeeding around the clock, and we want skin to skin contact around the clock. We want to make sure that we manage the milk appropriately. So we have refrigerators with individual bins for milk and freezers. All the milk is carefully labeled and stored, and we actually do barcoding to make sure the right baby gets the right milk. We give guidance to parents so they are aware of the small amounts of colostrum that are expected to be produced. And we save all of the milk, even if it's only enough to put on a swab to do human milk oral care. We ask the parents to label the colostrum in the exact order that it was expressed. We save the colostrum separately, and provided the baby is being planned to be fed within 96 hours, we would keep all that milk in the refrigerator. We would not freeze it. We start human milk oral care right away as well. We use a 96-hour store time because we still have maximal white blood cell activity at that point in time. And if we freeze milk, what happens is we destroy some of those beneficial components of human milk with freezing. So this means that the bedside nurse has to be very aware of milk supply. They need to know 24-hour milk production of the mother. They need to know how much the baby needs. And we need to be constantly paying attention to the supply of milk on hand and be aware of any feeding interruption that may happen. We have a lot of freezers. We track all that milk electronically through the EMR. We don't really ever go into the freezers unless a parent decides to stop breastfeeding or pumping. And so all of the milk, as I said, is scanned in. We only go into the freezers if there's no fresh milk available. And quite frankly, many of our people end up donating all this pumped milk to our milk bank. We have so much milk that our parents are really able to sustain our milk bank and be able to give their extra milk to feed the babies in need. So oral care and feeding of human milk, back in 2004 when I first published, oral care had not been researched, so it was added to my model in 2018. We start oral care immediately as after birth, as soon as there are drops of colostrum available. This baby here is on extracorporeal membrane oxygenation, so she's on ECMO. She had a diaphragmatic hernia. She was very critically ill. She tried to die a lot of times on us. This is a picture of her dad doing oral care. So our standard is that babies get oral care every 2 to 3 hours around the clock until the baby is able to take milk by mouth. And that is that baby who is critically ill as a toddler. And so critically ill child or critically ill baby to a healthy toddler. And she continues to be healthy. She continues to be thriving. So human milk doesn't just save lives, but it also improves the quality of life. One of the landmark findings that we also had is that for people who are pumping and have sick babies, being able to do oral care really benefits from that. it really benefits them. It makes them feel included in their childcare. It makes them motivated to want to pump. It makes them feel like they are making progress. So oral care is very important. When we start the enteral feeds, we always want to start with colostrum first in the order that it was expressed. And during the period of feed advancement, we 100% want to avoid giving a baby formula. We would use pasteurized donor human milk as a bridge to parents' own milk. We have our own human milk management center that is able to optimize milk. And as of 2015, we also became our own milk bank. Step 5 is skin-to-skin contact. Continuous uninterrupted skin-to-skin might not be an option for all babies. We have some really critically ill babies that we take care of, but as soon as the baby is physiologically stable, we would want them to be in skin-to-skin contact. I don't have to tell you all about all the benefits of skin-to-skin. It's one of the most evidence-based practices we can do, yet I see all over the world babies not being held skin to skin. And I see all over the world parents being separated from their babies. So we have to prioritize skin to skin contact. Step 6 of the model is about non-nutritive sucking. The original BFHI says no pacifiers and no bottle nipples, but the updated version of BFHI actually allows for those things. But if the parent's goal is to breastfeed, then we want to be able to get that baby to the breast. So as soon as the baby is extubated, or if the baby was never intubated, we would want to put that baby to the breast for practice sessions. So this baby here is that baby who had a diaphragmatic hernia and was on ECMO for 32 days. We have the parent pump and completely empty the breast until they don't have any more jets of milk in an extra 2 minutes. And then we position them for their tube feeding session while they're at the breast, okay? So the baby can get that experience of that nice full tummy associated with being at the breast. Transitioning to breast needs to be a detailed process. If you've ever heard the term discharge planning, starts on day of admission. If people's goal is to breastfeed at the breast, that transition to breast needs to start on day of admission. So we've published about our transition to breast pathway, which is basically my 10-step model, but just put into a visually pleasing table that can hang at the bedside so that the parent and the nurse are able to be able to see where they are in that process of transitioning to breast. This was further demonstrated in a project in Minnesota where this nurse utilized my 10-step model, and they did a project called Encourage, Assess, and Transition. So they were able to significantly increase the number of babies who went to breast for their first feed, and they also increased the use of test weights. Step 8 is the evaluation of milk transfer. The number one concern of women worldwide is knowing how my baby is getting enough. And I do see that someone has their hand up, Anita. I'm going to do all the questions at the end of the presentation so I can get through my presentation, but I do see your hand. And we want to use the baby weigh scale to validate that indeed the baby transferred milk. We know that clinical cues, unfortunately, are not accurate in telling us how well a baby does at the breast. And so if we really want to know that a baby is effectively feeding, the only way to document milk transfer is by using an accurate scale that is accurate to plus or minus 1 or 2 grams. We then want to support that family to be able to take their baby home. So we put the parent in charge of breastfeeding at this point in time. We really tell that mother that you're in charge of everything. The nurse is just here to support you. So there's a comfortable chair at every bedside. There's a warmer for warming human milk. There's a baby weight scale to measure milk transfer. And then there's the breast pump with initiation technology. So the parent has everything at their point of care. We also do cue-based feeding or infant-driven feeding, which is something that can be very hard for people to do in the NICU, but is essential for ensuring that babies can go to the breast and breastfeed effectively at home. So we recommend that the mother is there for as many hours of the day or night. We have them breastfeed on demand or on cue. And then we only supplement at the end of a time period if the baby does not meet their goal. There should not be any rules that say a baby has to be a certain gestational age or a certain weight. In this research from Sweden, they showed that babies were showing rooting, grasping, and sucking from 29 weeks, longer sucking bursts at 31 weeks, and that babies who were in Sweden were able to achieve complete breastfeeding at a median of 35 weeks, and that was a range of 32 to 38. Now, one of the things you have to remember about Sweden is in Sweden, parents are expected to be in the nursery 24 hours a day, 7 days a week, and their baby is in continuous uninterrupted skin to skin on the parent's chest from birth. So for some of our outcomes at Children's Hospital of Philadelphia, our human milk rates at discharge are very high, approaching 100%. When we checked on people post-birth after they went home, we found that we had very high rates of breastfeeding continuation. The mean and median breastfeeding duration was 8 months, and we had people who breastfed for over 2 years or 30 months. We also had higher rates of exclusivity when compared to national data, where we looked at what the CDC reported at 3 months and 6 months. And our CHOP mothers were providing about twice as much human milk compared to both national and Pennsylvania data, and they were exceeding the goals set by our government in healthy people. We further published an article about our tailored prenatal nutrition program. This is a one-on-one consultation that is done. And what we wanted to do was look at what was the impact of that. We wanted to see if by having a one-on-one nutrition consult, if we would change their decisions to want to start breastfeeding, and then if that would impact them breastfeeding not only in the hospital stay, but also post-discharge. And we compared that data to, again, the data from the Centers for Disease Control and Prevention, who track our national breastfeeding rates. So you can see that all of the outcome data were statistically significantly higher, with almost 100% of people initiating breastfeeding. Any breastfeeding at 3 months was almost 90%. The exclusive breastfeeding rate at 3 months was 60%, which was statistically significantly higher. Any breastfeeding at 6 months was almost 77%, so almost 20% higher than national data. And exclusive breastfeeding at 6 months was 20% higher. And then any breastfeeding at 12 months was also about 15% higher. And the CDC in the US doesn't even report upon breastfeeding beyond a year. But a full 1/3 of our parents breastfed for over a year. So when we're talking about babies who require intensive care, it's not just the baby being at the breast. The baby receiving human milk is also of critical importance, and we need to be able to support that parent and that family with whatever works for them and for their baby's diagnosis. We save a lot of babies in the US that other countries do not save, and we have a lot of babies who are critically ill, and some of them can spend their whole first year of life in our neonatal intensive care unit. We really need to prioritize for families that they understand that human milk is absolutely essential. That if we have a sick baby, we do not really want to put anything else in that baby's belly except for parents' own milk. We don't ever want to use formula. And if we didn't have the parents' own milk available, then we would use pasteurized donor human milk. And again, if the parent's goal is to direct breastfeed, we want to support that. But some babies are not ever going to be able to direct breastfeed because of their diagnoses. So we have to do some give and take based on the health of the baby and also the parent's goal. But understanding that if the baby gets human milk, that's of paramount importance. And remember, the World Health Organization, in their definition of exclusive breastfeeding, don't say that the baby has to be at the breast. They say it's 100% human milk diet. So this is a quote from a parent, and that baby had a giant omphalocele. She talks about how important it was to be able to breastfeed him before a year, but beyond a year. And she talks about the fact that by her being able to breastfeed her son, it was one of the greatest gifts that her son could have gotten. And it was so important to her, and it really meant a lot that she was supported in her goals to provide milk to her baby. Working with babies who are critically ill and working with parents who are pump dependent or have to depend on expressing to sustain milk supply is really, really hard work. And we need to give them credit for all the work they do, and we need to support them. And, this quote from this mom here, she says, she feels like a mom, right? She feels like a mom that she finally is able to put her baby to the breast. So this is my last slide. We do have infographics developed on my model. I would love to see people in Indonesia and other parts of the world also implement my model. Nothing would make me happier. One of the things that I would really love to see is people also consider publishing their findings, because I have lots of places who have implemented all of these 10 steps, but not all of them have collected data and have been able to publish their outcome findings. And I think that's so important, because we want to be able to show, like we have in other parts of the world, that it is possible to improve human milk rates, not only on initiation, not only on discharge from the hospital, but also beyond the hospital stay. And we've demonstrated that parents can provide milk for their babies well over a first year of life. So I will stop sharing now. And at this point, I am happy to answer questions, and I can look in the chat, but also I did see someone who had their hand raised. So if they do want to unmute themselves and ask their question, that is fine with me too.
Okay, thank you, Professor Spatz. We all hear and watch how your outstanding presentation, your material is insightful, practical, and also we appreciate your material. But I bahwa Profesor Spatz baru saja memaparkan 10 langkah dari model bagaimana menerapkan mempromosikan dan melindungi human milk atau ASI dan menyusui. Jadi memang model beliau ini diterapkan pada bayi-bayi dengan kondisi vulnerable atau rentan, di mana bayi-bayi tersebut dilakukan perawatan di NICU ya, atau Neonatal Intensive Care Unit. Dan dari model Profesor Spatz kita bisa melihat bahwa ada 10 langkah ini merupakan satu kegiatan yang sangat terencana dan melibatkan semua pihak. Kita lihat ada langkah pertama itu harus ada informed decision, jadi orang tua dan keluarga harus sangat terlibat di dalam kegiatan breastfeeding pada vulnerable infants ini. Kalau teman-teman menyimak tadi ada 10 langkah, nah barangkali maybe there are questions dari Anda semua ya terkait dengan langkah-langkah dari model Profesor Spatz. Kami persilahkan kepada audiens untuk membuka mic-nya dan mengajukan pertanyaan. We welcome you to open your mic and ask the question to Profesor Spatz. Silakan.
Okay, thank you. My name is Aprila Esrani from Nutrition and Dietetics Department. Dr. Spatz, I really love how the 10-step emphasize holistic support for mothers, but I'm really curious, what role do fathers or family members play in this step and how we engage them more actively in the breastfeeding process? Thank you.
It's a fabulous question, and it's one that we do all the time. And so I didn't get to talk too much about it, but when a person has their prenatal nutrition consult with us, we actually ask them while they're still pregnant to bring the dad, grandmom, sister, cousin, anyone. The whole family is welcome to come. And so we tell the family that mama, her only job is to eat, sleep, and make milk for the baby. That's the only job of the mama. And everyone else's job is to do everything else. So we ask the dad to operate the breast pump. We ask the dad to wash the pump kit. We ask the dad to, sterilize the equipment. A lot of times, especially if it's a cesarean birth, the dad might be the first one who gets to do the human milk oral care. We ask the grandmom and the sisters and the family member to make sure that the mom has food, that mom has water, that she's being taken care of. And so we want that whole family to be that village who is supporting that mom in her lactation journey. So her job is making the milk to take care of the baby, and the rest of the family's job is everything else. And we want to give them concrete jobs because they need to know what they should do to support them.
Okay, this is really hard work for a professor, because when we work with other family members, so it's not very easy because they have all maybe business or work to do, and they think maybe the mother is not the prioritized. And how would you work with them?
Well, I think that that's a global problem. I mean, in America, we don't have paid leave, right? So our parents are going back to work, they're going back to school. And so that is a very common thing that happens. But I think one of the things you want to think about is if we aren't talking to the families, and if we aren't telling them their role and how important it is to support the mother, then they have no idea. And they just think like, well, I'm just going to go about my business. I have to work. I have to take care of other things because no one's giving them a job. So I would empower all of you to consider giving every single family member at least one job to do in that lactation journey.
Ya, mungkin teman-teman mendengar sendiri ya bagaimana sebenarnya ternyata untuk mendukung ibu yang menyusui, mother with vulnerable infants yang mungkin dirawat di NICU, itu kita perlu bekerja, kita harus bekerja dengan seluruh anggota keluarga, suaminya, orang tuanya, mungkin adiknya atau siapapun yang berada di rumah. Jadi pekerjaan ibu yang memiliki bayi yang vulnerable itu adalah untuk menghasilkan ASI saja. Jadi bagaimana caranya, ini adalah PR kita sebagai tenaga kesehatan ya, untuk mempromosikan ya bagaimana human milk itu adalah medication for vulnerable infants. Baik teman-teman, masih ada pertanyaan? Ini menarik sekali ya topiknya yang melibatkan nurse and also midwives dan tenaga kesehatan lain ya, mungkin teman-teman dari promosi kesehatan dan gizi, kita harus bekerja bersama di dalam mendukung ya pemberian breast milk pada vulnerable infants. Silakan teman-teman dibuka mikrofonnya dan ajukan pertanyaan kepada Profesor Spatz.
Thank you. Introduce my name Hani, student at Borneo Health Poltekkes. Indonesia has a strong and diverse social and cultural background, but these aspects sometimes become challenged in implementing optimal breastfeeding practice. So, in your opinion, how can we as future health professionals play an active role in overcoming the social and cultural barriers to ensure optimal breastfeeding practices are widely and sustainably applied in Indonesian communities? Thank you.
It's a great question. And Indonesia is like the rest of the world. Believe it or not, we have more in common in the world than we don't. And so the social and cultural factors exist in every single country. And earlier today, I was giving a lecture. It was about the environment and the impact of the environment on health. And so these were students who were not just nursing students, but from across the university. And I said to them, how many of you have ever thought about human milk and lactation as a public health issue? And people were like, no idea about the fact that we all need to care about this. So I think one of the things that in Indonesia would be important is to elevate, right? To elevate that messaging about the critical need for people to be able to have the support and the interventions necessary so that they can not only start breastfeeding their baby, but they can provide milk for long term. So that would include things like public health campaigns. That would include things like having adequate resources for parents. That would include things like maybe even considering teaching children in the school curriculum about human lactation as being just part of the life cycle. So there's lots of opportunities for all of us to think about ways in which we can change the cultural practices of our countries, no matter where we live. Thank you.
Okay, thank you for your answer, Professor. Because of the limited time we have, so we would like to thank you for you to join us today in our international conference, and we would like to give you the virtual certificate of speaker. Please accept this certificate. And
Thank
we
you.
would like to, maybe in the future we will have a collaboration in this field of knowledge.
Great. And people can feel free to email me any questions that we did not get to answer. I'm happy to do that.
Okay.
And I thank you for inviting me. And I did stay up past my bedtime.
Thank you, and I'm sorry for the late time there in Philadelphia. Oke, thank you, Professor. Teman-teman panitia, apakah ada virtual certificate yang mau ditampilkan? Okay, this is the certificate from Health Polytechnic of East Kalimantan for Professor Diane L. Spatz, PhD RNBC, as attending as speaker in our EBHIC and ICLM today. Thank you again for Professor. Dan kawan-kawan audiens, setelah pembicara pertama tadi kita beranjak ke pembicara kedua. Pembicara kedua adalah Dr. Sri Devi Mutu. Beliau adalah seorang saintis, seorang pengajar dari Malaysia, dan beliau memiliki banyak sekali hasil penelitian, dan beliau merupakan profesional dan kualifikasinya adalah Master in Nursing Education from Lincoln University, Malaysia. She has 26 years in nursing profession, atau 26 tahun sudah bekerja di profesi keperawatan dan memiliki 20 tahun pengalaman klinis or clinical experience in labor and delivery unit, jadi di maternal nursing. And also she has so many research, and the title atau judul dari penampilan beliau di hari ini adalah terkait dengan teknologi teman-teman panitia mungkin bisa tampilkan judul dari pemaparan Dr. Sri Devi. Ya. Selamat pagi, good morning.
Good pagi and good morning, Madam.
Yes, my name is Era. You can call me Era. And today you will give us presentation about revolutioning lactation monitoring and counseling in maternal health.
Yes.
Okay, thank you, and the floor is yours.
Thank you, Madam. Okay, so let me introduce a little bit about my experience. My name is there, my qualifications is there, and today I will be speaking about this topic based on my experience, my previous experience in my clinical working experience especially in Saudi Arabia, in Singapore, and also in Malaysia. It's solely based on what I have observed and what I have analyzed and what I would suggest in future. Okay, so today I'm going to present about revolutionizing lactation monitoring and counseling in maternal health. Can you go to the next slide? Okay, so for today we'll be looking at I would want to present on how to the current barriers or challenges to breastfeeding, and also to recognize digital tools for lactation monitoring and counseling, to review the recent developments in all those 3 countries that I have mentioned earlier, and also to get practical steps and implement and to evaluate digital lactation programs. So we are generally going to speak about how artificial intelligence can be absorbed into lactation process, and also the suggestions of future implementations of enhancing the support of maternal infant outcomes. Next. Okay, so breastfeeding is a cornerstone of maternal and infant health. Historically, all the while lactation has been monitored through direct observation and manual documentation. However, as healthcare digitalization advances right now, we integrate mobile applications, teleconsultation, and artificial intelligence to provide continuous and data-driven lactation support. So the traditional way of lactation monitoring has been done manually all this while, right? We have been doing manual records in charts and also face-to-face observation. Besides that, we also have introduced certain digital tools to transform the manual method into AI method, which using technology by doing tracking and also assessment to find out what are the problems or the complications might occur out of during the lactation process. So from there, we can continue with counseling and the care, the aftercare after during the whole lactation process. Okay. So why is it important to monitor lactation? Lactation, it ensures, we want to ensure that the mother has got enough milk to produce in order to feed the infant so that the infant does not end in malnutrition. Okay, so the child has, if let's say now the mother has delivered a preterm baby, so we need to know that the preterm baby actually, the milk which is produced by the mother is also suitable for the preterm baby. So if you see in the market, there are various kinds of formula milks, right? So there are milks for, especially for preterm babies. So if the mother is lactate, if the mother is breastfeeding, usually the milk that is produced is according to the period of gestation of the baby. That means if the baby is preterm, the mother's milk is suitable for a preterm baby. Okay? And another reason why we need to monitor is also to detect early issues such as breast engorgement or mastitis or cracked nipples. What are the reasons for all these problems? Probably because of poor method, poor technique of breastfeeding. Besides that, we are also supporting the breastfeeding goals from World Health Organization, which says that essential breastfeeding is preferably for the first 6 months, and it's also to guide personal counseling and also intervention for future process. So we are also not only guiding the mothers, we are also guiding the lactational nurses or the lactation personnel in order to teach them how to provide counseling and also intervention to the mothers during the whole process. Next. Okay, so how look at the manual lactation monitoring. Usually the manual methods are always using charts, logbooks, weight tracking, observation, and verbal reporting. So like what we see in the nursery, usually after a delivery, when we send the baby to the nursery, the babies are usually fed uh, either with formula milk or with breast milk. So when the baby is breastfeeding, most of the hospitals now are into baby breastfeeding, fully breastfeeding program. Okay, so once the baby is has started on breastfeeding, we have got individual charts to record how much the baby is taking, the volume of milk given, and also the duration, and also if the output of the baby, whether it's tally with the input. So what are the limitations that we have when we are doing a manual monitoring? Time consuming. So we need manpower, we need people, personnel, professional trained personnel in order to monitor a baby in the nursery. And also there might be error prone, there might be some errors probably when they are feeding, there might be errors in charting, okay, in documentation. And also there's inconsistent and also limited data sharing. So because it's all documented in black and white, there is limitation in retaining the data, okay? The privacy and the confidentiality must be maintained. So these are one of the challenges of a manual lactation monitoring. Okay, so in the manual era of lactation counseling, lactation counseling is typically a face-to-face process. It is done usually in the clinics when the mother comes for a postnatal checkup. The mother brings the baby, and then when she's being reviewed by the doctor or the nurse or the midwife in charge, they usually will teach the mother how to breastfeed, what's the correct technique, or if there's any issues, how to troubleshoot issues face to face. Okay, and also it depends on the provider to expertise and availability. If the professional personnel is well trained, has got proper knowledge in providing her expertise, if let's say she's a trained lactation nurse, then she is able to deliver 100% from what the knowledge that she has correctly to the mother. Often reactive than proactive. So it's usually a one-way communication, a one-way teaching method whereby the medical personnel is explaining to the mother and the mother is receiving the information from the medical person. But usually it's just a one-way education because the mother has only option to absorb, and she probably her knowledge is not much, so she can't share or she can't predict whatever is going to happen in future during the breastfeeding process. And most of the time it's all paper based, as when there is a paper charting process, there will be this inconsistency and in the documentation process. Okay, so the digital transformation in maternal health, as far at this point of time, there is rise of mobile health and telelactation. So there are lots of apps, mobile applications, which is connecting, explaining about telelactation, support groups to peer groups to help those mothers breastfeeding. They exchange their experience and problem solving among them. There's also integration of electronic health records whereby every documentation, instead of paper documentation and charting, we do it in an electronic system. And there are also AI-based lactation analytics and decision support tools such as a breast pump, which has got a Bluetooth facilities, has been introduced in the market to enable the mothers to easily get support and troubleshoot their issues. There are also smart and wearable connective devices such as the breast pump. You can actually connect the device wireless, also connect to your phone, to your mobile application through an application. So through the application, they can actually identify what are the types of the duration of feeding and when is the next duration the feeding due, and what are whether the amount of feeding is enough for the child, and what are the risk factors that might be foreseen from the process. Okay. Next. Digital tools for lactation monitoring. Okay, that's what I mentioned before. The mobile apps. There are a few mobile apps such as Love app and My Medela. I think My Medela is a breast pump machine which is used worldwide. They have come up with mobile apps. So the apps is actually connected with the breast pump to track feeding, the duration of the feeding, the patterns of feeding, because breastfeeding is not fixed, right? It's on demand. So it actually records like how we do it on a glucometer, right? So this is on a breast pump. So it records every detail during the feeding. And also smart wearables like Bluetooth pumps, it measures the volume and also the suction power of during the pumping session. Digital feeding sensors, it's assessing the intake of via weight difference. So when the baby is being fed and the baby is has a past motion or past urine, there is weight. The app helps you have to enter the weight of the diapers that you're going to change, and then from there it will calculate the number of calories and the amount of fluid intake and output, just like what we do in the intake output chart. So the AI platforms is analyzing data and predict lactation issues. From all this, the main ultimate goal is for the platform to analyze whatever data that have put in, so that from the data they can predict, they can foresee any issues with the whole feeding process, and the management can be done as soon as possible. Next. So telelactation and virtual counseling. Virtual consultations provide 24/7 access to care. So this is something like a WhatsApp app, like you can actually communicate through a WhatsApp chat groups, and it's 24/7. So whenever the mother has issues, even day or night, she can always go to the app and go into the chat and ask or rectify issues that she needs. And then improved access for rural or homebound mothers. So there are, like in Malaysia, right, when the mothers deliver, most of them are working nowadays, working mothers. So when they deliver, they have got 3 months of confinement leave, and most of the time they are back to their home, to their mom or their mother-in-law's place, where it is most of the time out of the city. So once they are out of the city, they are out of access to the hospital, to the main hospital. So this is one of the easy method for them to access through a chat, and also for homebound mothers, for mothers who are in confinement in Asian settings. The confinement mothers usually they don't go out of the house, right, for a few days, beginning from the beginning of the delivery day. So this is one of the easy methods for them to access. Supports family involvement in early issue resolution. So this app can be also accessed by husband or by any other family members on behalf of the mother, because let's say if the mother is on some other task, okay, she can't do it by herself, or she has limitations in chat, in typing the messages, and also the family members can also support her during that time. And it also maintains the continuity of care during pandemic. So in we have all gone through COVID for 2 years, and how it was, we couldn't have face to face, everything was online and in the app. So in future, if we hope it doesn't happen again, but in case if the similar situation happens, so this is the best method to for the resolution. Okay, next. Okay, so let's look at what Malaysia has got in the latest update for the AI aspect. Okay, so most of the hospitals in Malaysia right now has gone into full breastfeeding programs. Okay, and it's from Malaysian Ministry of Health and also National Maternal Child Health. They are giving full support and guidance to emphasize exclusive breastfeeding and support. Okay, so this is important because we need proper governance to come up with a policy and also the guidelines so that the subsequent interventions can be taken. So there are also smartphone app pilots such as BFF style and all to show how to breastfeed, the technique of breastfeeding, the position, and also how to prevent complications during breastfeeding. So this is usually accessible. The mother can access way before delivery. During the antenatal period, she can always have the access for this. Key challenge, equitable access across urban, rural, and multilingual groups. So the main challenge for this is the mothers who are in the rural and rural areas, it's quite difficult to access probably because the internet connections might be a little weak in the rural areas. So this requires a good Wi-Fi connection or internet data and everything. So this might be one of the challenges that we are having right now. Next, we look at what's happening in Singapore. Okay, so Singapore generally, as we know, is a fast-moving country. Everything moves fast. They are very digitalized, and their education level, literacy level is very high. They have got good technologies, advanced technologies, and all. So it is easy because they have got high digital penetration and telehealth uptake. They have got good data, internet connections. They have got, it's a small country, so it's easy for them to access. There are hardly any rural area in Singapore. Everywhere is connected, so there is no challenges in access. And then tele-lactation service via private or public telehealth platforms. Okay, so most of the newer generation who is having babies right now in Singapore are mostly foreigners, besides the locals. So the foreigners are well equipped. We have got lots of Japanese patients, Indian patients, all those expats who come and work in Singapore, they decide to deliver in Singapore. So when they deliver, they are all equipped with every information that they need before they come for delivery. So they are basically well educated, well equipped with knowledge. So it's easy for us to um, penetrate all the knowledge to them through technologies. And also when the mothers admit to the hospitals are also equipped with AI because each labor ward has got a television which they can, while the patient is in early labor, she can always switch on and there's a lot of information she can read in the system in the television itself regarding breastfeeding and lactation and what are the support systems that she can find around her. And also there is complementary infrastructure like lactation pods. So lactation pods are like it's for example in every mall they have got a place for lactation, like a lactation room. So in the app itself they can access which is the nearest lactation pods that they can access and where are the places that has got these lactation pods near them. So it's easy for them to just rather than looking for proper place, with privacy and so on. And where else? The next slide is showing Saudi Arabia. Okay, in Saudi Arabia is totally different from Singapore. It's totally the opposite because the culture is conservative. The women there more they are not as open, and they preserve their privacy and their dignity a lot within them. So it's a bit difficult to penetrate through them. But then lately, the Ministry of Health in Saudi Arabia has been offering virtual lactation consultations across all regions. So there are patients quite comes from an Orthodox family, which is they are not comfortable with male doctors, even gynecologists. So lactation, they prefer consultations over a virtual consultation rather than direct, because they even when they go out, they have to cover their face, and they have to wear the abaya and everything. So it's easier for them during confinement, during postnatal period, for them to just have a virtual consultation whenever they need or they have issues regarding lactation. So studies shows that interest in culturally tailored mobile health interventions, so they prefer to have a virtual lactation consultation rather than a face-to-face. So this is a plus point, because through this we can actually they can actually go into a virtual consultation through mobile apps like what we are doing in Malaysia. But again, there is one challenge, another challenge, which is the geographical state of the country itself. It's a huge country, and the cities are far apart. So for them to deliver in one place, in place that they are living, and then to go home, to go back during their confinement, their postnatal period, to their mother's place or their hometown for a few months is quite difficult for them. They can't come back to the place that they deliver and see the doctor and have consultation from them. So it's similar to Malaysia. So these are the things that might give a challenge in this country. Next. Okay, so comparing to these all three countries, like in Malaysia, it looks promising because the Ministry of Health is giving a lot of effort and encouragement and support in order for us to go into a more technological method of monitoring mothers during lactation, whereas Singapore has already reached the point where most of them are already into telehealth and physical support spaces. But in Saudi, it is still in the beginning period of Ministry of Health starting a tele-lactation program, and also motivating and educating the mothers to breastfeed, because the motivation part itself is lacking among them, probably because they don't believe in family planning methods. Okay, so they deliver lots of babies, and the times that they come for delivery, the moment they finish deliver, they will be very tired. They can't even have energy to breastfeed. So it's quite difficult to motivate them to breastfeed. Nevertheless, the newer generation are understanding the benefits of breastfeeding, so it's a bit easier right now. Okay, so the benefits of digital lactation management. So what is compared to the manual management, right? What can we see in future when we move to the digital era? Okay, so there's enhanced accuracy and data continuity. So in digital documentation, everything is accurate. Okay, there is the timing and the amount, it's all recorded accurately. So there is consistency in the data documentation, and also it supports early problem identification. So when there is consistency in the data documentation, if there is any variance, any abnormalities, we can already foresee in advance if there is any risk factors or problem to occur soon during the whole process. So it also facilitates collaboration among healthcare teams, and this is done through the healthcare team in the hospital itself. Like let's say from the labor ward team, and also the nursery team, and also the NICU team, it makes things easier to communicate among them, and they can exchange ideas or exchange views on how to implement the digital lactation method. Empowers mothers through self-tracking and education. So the mother is actually practically she's hands-on with whatever she's doing. So when she communicates, let's say she goes into the telehealth lactation, or she goes into the WhatsApp chats and the chatbot booth, she is actually communicating directly with the professionals. So she can self-track her condition, and also she can educate, she gets knowledge, she's self-educated from whatever information that the professionals are giving her. Integration into maternal health systems. Okay, so how are we going to integrate all this data into the healthcare system? So it fits into maternal health policy and research analytics. So the policies and the research analytics have to be in line with the um, technologies that we're going to the technologies that we're going to introduce to the mothers. So that is the main motivational support that we're going to get, because without a proper policy, there is no way that we can start implementing whatever plans that we have. And then it also connects with electronic medical record and also national maternal database. So when we have got a digital documentation, it is proper and clear documents for us to do statistical analysis, and that will be handed over to the maternal database, so that the maternal and the child well-being can be monitored. And also it supports antenatal to postnatal continuity of care. So this digital information can be started as early as the antenatal period, okay, and it can be continued right up to the end of the breastfeeding session, which preferably we will motivate the mother to go up to 2 years. So there is a very long period of support and continuity of care for the mother. Okay, so there are challenges in implementing, actually, in fact, there are a lot of challenges in implementing digital artificial intelligence into lactation, because as far as we know, our mothers and grandmothers have been breastfeeding for a long time and without any digital technologies, and they did it as well. So it's quite difficult to explain to penetrate those knowledge and information to mothers, and to get their assurance that to assure them that this method is better than what they have been doing before. And we have to understand that not all that tasks can be taken over by technology. Okay, there are certain tasks, especially which involves emotions and privacies and confidentiality, which needs to be remained manually. Okay, so there is the first challenge is limited access in low resource settings. So in for example, in a rural area, there are limited access because probably the internet connection is not good, and financial aids are less. People with low economic status are more on a rural area, so they might not get a proper access to this. Second, the data security and privacy concerns. So whenever you have a digital documentation, you need to key in lots of data, personal data, confidential components in the documentation. So this might be one of the challenges because probably some mothers would not want to be revealed, especially in conservative countries like Saudi Arabia. They don't want their details to be in a social platform. Okay. The next is training needs for healthcare providers. So in order for us to move into technology, we definitely need healthcare providers, healthcare team members to be trained to give them the knowledge, the proper knowledge, and how to conduct and how to handle the technologies, um, the equipments that we are going to use in future, right? So that needs might be costly. It takes time. It takes lots of manpower as well, and also there must be a competency checks every now and then to be done on the professionals. Next, resistance to technology and adaptation. So when there is a resistance to technology, especially from mothers who is less exposed on the advancement, the technology advancement, it's quite hard to reassure them that technology can actually make things easier during the lactation process because their mindset is such that breastfeeding is something that comes naturally and the bonding it's something that does not need technology at all. So it's our duty as healthcare members to explain to them the importance of accepting the technology so that there are lots of um, improvement can be done, especially on the complications and the management part. And also it's a high setup and maintenance cost because all these equipments are costly, are expensive, and also you need to maintain the equipments by having the technicians to calibrate the machines and make sure it's in good condition, servicing every now and then. So it actually takes up lots of cost, especially in a hospital organization. Next. Okay, there are also some ethical and legal issues that we need to consider in transforming into a digital era. So we have to make sure that we have got informed consent for data collection and storage from the mother itself. So this part is going to be quite challenging because most of the mothers, firstly, they don't have time for this, and secondly, probably they might not even want to share certain data, especially when it comes to their privacy and confidentiality. Compliance with data protection regulations. So we need a proper regulation, a proper standard procedure and guidelines in order for us to be compliant and to have a standard uniform practice. So the policies and the procedures need to be done accurately and need to be approved and accredited before it's given and used in the organization. Next is ensuring equity and access for all mothers. So, how do we get an access? How do we create access for mothers who has delivered in a hospital and who has gone back to their hometown to be with their parents, to be looked after by their mothers or their mother-in-laws, which is out of the city, so these are things that we need to identify. How are we going to access to these people? So one of the method that we are using here in Malaysia is that we have got home visits, right, in um, the clinics, the healthcare clinics in the rural areas. So they conduct home visits. So that's one of the access that we can actually go through to all mothers who have gone to their own home. Preserving empathy in digital interactions. So As we know, digital interaction, texting is a way of communication which does not involve emotions. Okay, yes, you have emojis, you can use emojis, but it's not the same as you speaking with your voice tone and also face to face with your body language. So, breastfeeding, it involves lots of bonding and emotions and empathy and uh, uh, sharing of emotions and so on. So it's quite difficult to have it in text. Okay, next, role of nurses and midwives in digital lactation care. So these are the things that I would suggest as a healthcare or clinical professional who works directly with the patient. You act as a digital mediators between mother and technology. So you as an educator, okay, a healthcare member is also an educator to the patients. So you will be, you need to, firstly, you need to know about the technology in order for you to teach the mother. So once you master the knowledge, the equipments, how to use the equipments, how to troubleshoot, what are the problems that you might occur from the machines and how to service the machines on time and so on. You need to know all this before you mediate to the mothers, before you transfer the knowledge to the mother. Okay, so when you have all this, the mother, when they listen to your explanation, they know that you know what you're saying, and it will build their confidence and reassurance. Next, you educate and guide mothers in using digital tools, as what I said before. And then you interpret data for clinical decision making. So whatever data from the tools that you have given, you need to analyze, you need to make sure that it is correctly documented and it's accurate, and then you have to analyze it in order for you to if there's any risk factor you can identify, and then you can implement your future plans of management. Next, the last one is to advocate for ethical and safe digital health use. So you as advocate, you need to make sure that the patient's safety, the patient's confidentiality, and the patient's privacy and dignity is safeguarded, okay, by using all these tools. Because if anything happens, be prepared, the patient is going to sue you, and it will backfire, and the feedback is not going to be nice. So you need to make sure that the patient's dignity is always safeguarded. Okay, now this is a case example. Let's say a mother, she uses a smart pump, okay, and it's linked to an application app. And consider when her milk volume decreases, okay, she's having problem now because her milk volume decreased. So she consults uh, and reviews data remotely from the place wherever she are at that point of time, and advises appropriate interventions given by the consultant. So when she come up with a problem, she explains that she's having less milk production, and then the consultant gives her a solution. So what is the outcome? It improves milk supply, and the maternal confidence is higher, and the patient, the mother, will feel satisfied because it is actually solved her problem. Okay, so that's how we gain the reassurance of the mother. Next. Okay, so the future trends in digital lactation. So what are we looking into? Probably couple of years from now, the AI and predictive analytics for early detection of use of issues. So we want this digital transformation to happen because it makes things easier for healthcare members in order for us to predict what are the issues that is going to occur in advance. Okay, so we can be well prepared with the management plan. We also like virtual reality and training and simulation tools. We are there are lots of tools which are being designed, which are being introduced to hospitals, and also once the tools is being introduced, the representative of those companies, they conduct trainings to the staff, okay, on how to use the tools. So these are the things that is happening right now in the clinical area in hospitals, and the staff have to be prepared to absorb whatever knowledge that they're going to get from the training. Integration with wearable maternal health systems. So let's say the breast pump. The mother is going to bring home the breast pump and keep it with her throughout her breastfeeding process. So we need to integrate those pumps, those whatever equipment tools into our system so that when it catches the data, the documentation part in the digital system, it can be collaborated and integrated in our system so that we can monitor and analyze and also um, interpret to detect early risk factors. Blockchain for secure record sharing. So we need to find a secure app website in order to protect the patient's privacy and confidentiality according to the ethical considerations. Global digital lactation networks and data collaboration. So this is one of the example that we are having right now, an international conference, because we share knowledge, we share experience, uh, we share what are the which are the areas where um, there is advancement in technology so that it can be taken into consideration and shared among the other organization in other countries around the world. Next. Okay, so we have come to the end of my topic. Uh, let's look at the summary. Digital lactation monitoring enhance accuracy and accessibility. So when there is lactation, a digital monitoring during the process, through the documentation that we're going to see, it is accurate and reliable. Okay, and the nurses and midwives are key to integrating technology and empathy. So the main role of a nurse, a midwife, and also the doctors are to assure the mother that by using technology, by moving towards transforming into technology, it can uh, resolve or it can give a good outcome on the maternal and also the child health well-being. Continuous education and ethical governance are essential. So we still need continuous support from the government, from the policymakers, from the Ministry of Health in each place, each country, in order for us to have support for us to continue with whatever transformation that we're going to do, and also continuous education in the organization itself on educating the healthcare team members on how to uh, transform into digital lactation. The future is connected, personalized, and data driven. So we are looking at future. We have got visions. Each organization have got their own goals on how to um, be more better or improve on in terms of management of the patients and the for a better outcome. Okay, so these are the take-home messages that I would give today to all the participants. Technology is a complement, okay, but it's not a human to replace care for the patient. So it just complements the care that we are giving. It works together with humans in order to deliver whole complete care. Okay, but it can never take over a human's responsibility 100%. Digital lactation support empowers mothers and professionals. So this is something that we need to reassure the mother that the digital transformation, it promises excellent maternal care and also outcome for the mother. Manual expertise and digital innovation equals to better maternal outcome. Okay, so that's what I was telling earlier. When the healthcare members and also combined with the digital tools, it will give a better outcome to the mother and also the child. Okay, so if you want to, that is a further reference if you want to do some reading in future.
Well, thank you, Ms. Sridevi, for your presentation. Let me explain this little for our audiences. Jadi rekan-rekan sekalian, baik perawat maupun bidan, serta mungkin profesional kesehatan yang lainnya, baru saja narasumber kedua kita, Dr. Ms. Sridevi Mutu, memaparkan materinya mengenai digitalisasi di dalam perawatan kesehatan maternal. Dari pemaparan beliau tadi kita bisa melihat bahwa monitoring dan pencatatan laktasi yang selama ini digunakan adalah menggunakan cara manual dan memiliki beberapa tantangan yang kemudian diberikan solusi dengan menggunakan digitalisasi. Dan kita mendengar sendiri tadi bagaimana digitalisasi pada perawatan maternal itu dapat diterapkan dan ditampilkan perbandingannya, komparasi penerapannya di negara Malaysia, Singapura dan juga Kingdom of Saudi Arabia. Dan teman-teman mungkin masih memiliki pertanyaan untuk diajukan kepada narasumber kita. Saya persilahkan untuk membuka mikrofon dan langsung mengajukan pertanyaan. Silakan.
Excuse me, my name is Serli Marlina. I'm studying from Poltekkes Kemenkes Kalimantan Timur in Indonesia. I would like to ask a question. How can lactation counselor adapt their approach to address the unique cultural, social, and economic factors that influence a mother's breastfeeding experience, particularly in the context of technological developments?
Okay, thank you for your question. Firstly, the healthcare member itself must be equipped with knowledge. You need to know what to deliver to the mother and how to assure the mother in order for the mother to be confident and understand how to use the tools that you're going to introduce to her. So in order for you to do that, you need to equip yourself with knowledge. You need to know how to explain to the mother and also offer the mother help in case if she needs, if she has problems in future with the tools that she's going to use. Where can she ask for help? Where can she go to ask for help? Whether it's from the from you, from other healthcare members, or also from the company representative of the tools. Okay.
Ya, jadi narasumber kita menyampaikan bahwa di dalam memberikan informasi kepada ibu yang menggunakan aplikasi, tentu saja kita sebagai tenaga kesehatan harus memiliki kemampuan dasar di dalam menggunakan aplikasi tersebut. Jadi we have to be trained ya, bahwa sebenarnya kita harus di training dulu, juga harus diberikan pemahaman dan pelatihan bagaimana cara menggunakan aplikasi yang sesuai di dalam monitoring dan pencatatan laktasi. Apakah dipahami untuk penanya? Paham? Baik. Baik, kami persilakan kepada audiens yang berikutnya yang ingin bertanya kepada narasumber kita. Silakan. Ya, langsung di open mic, silakan langsung bicara.
Okay, thank you very much for wonderful presentation, Ms. Sridevi. I have several questions, but I try to narrow it down into simple question. The first question is about what you said on balancing technology and human connections. How can we make sure that technology support not replace the personal bond between nurses and mothers? Like for example, apps can record expressions and feeding times. By many moms still say emotional supports from nurse and makes huge differences. And how do we keep that human touch while using digital tools? And the second question is about using data for real impact. What kind of data that do you think find most valuable to show real improvement for mothers and babies? For example, like do you think it's more useful to track breastfeeding durations, milk volume, or mother confidence level after digital counseling? That will be all. Thank you.
Okay, that was a long question. The first question. Let me answer the first question. So, how your question was how to maintain the relationship, basically the relationship between the patient and the healthcare team member, right? I mean the face-to-face relationship, the emotions part. Okay, as what I said, technology cannot replace on emotions. They can only complement. They can only make things easier for us in order for us to analyze data and predict risk factors and issues. But it is not going to reassure, it's not going to make the patient feel confident or secure. Okay, so our part is still important, whereby when you explain to the patient, you introduce something new, especially a technology, a tool or an app, you still, at the end of your explanation, you will tell the patient that, okay, if you have any issues, you come back to me. We are always here to help you. Okay, so that the patient also has got the security and confidence, not like we hand over everything to the technology and then the chat box will only give you options to ask questions and then you cannot ask questions out of there. So you must give them another option. If you can't resolve your issues from that, then there's another option that we are always here to help you and to support you. And going to your next question, can you repeat the question again?
Oke, apakah paham penjelasan dari narasumber?
Dan yang kedua.
Do you still have...
Okay, sorry. I need permission to unmute my speaker. The second question is about data, using data for real impact. What do you think, what kind of data do you find most valuable to show real improvement for mothers and babies? Because it's kind of like a lot to input in one system or apps that has been using by moms, like tracking breastfeeding durations or probably milk volume or perhaps mother confidence level after digital counseling. Which one do you think is most valuable on this between all of this data?
Okay, thank you for that question. We first of all we need to know what's our ultimate goal, what's our objective. What is the main thing that you want from the outcome? Okay, we basically want the improvement in maternal and also child health. So how do you want to make sure that the baby has got enough nutrition by looking at the amount feed, the duration of feed, whether the mother is feeding on the right breast or the left breast, and how long she's feeding, how much the baby is taking, as well as how much is the output. So that all this data can actually can give us a clear picture on if the baby is having enough nutrition and hydration, or the baby is going to go into dehydration, and then there will be implementation after that. In terms of confidence, as what I answered in the first question, the confidence is always going to come from us. It's never going to come from the technology. Yeah.
Baik, apakah sudah dipahami jawabannya, adik? Baik, thank you for Ms. Sri Devi for your answer, and I think because of our time limitations, so this is we come to the end of your the session, and we want to give you the certificate of speaker. Tolong kepada panitia untuk ditampilkan. Dan kami menunggu untuk di masa yang akan datang kita bisa berkolaborasi untuk tema selanjutnya, Miss Sri Devi. This certificate is presented to you from us here in Samarinda, Kalimantan Timur. Thank you for your attendance.
Thank you. Thank you so much.
Thank you so much. Oke, Bapak Ibu, rekan sekalian, mahasiswa yang hadir di ruang virtual Zoom maupun yang menyaksikan langsung di saluran YouTube kami mengucapkan banyak terima kasih sudah mengikuti 2 dari 5 narasumber yang akan tampil pada kegiatan kita di hari ini. Dan untuk yang selanjutnya kita akan menampilkan salah satu narasumber dari Poltekkes Kaltim, yaitu yang kita hormati Ibu Hajah Bidan Evi, Hajah Evi Nurrahma, tolong ditampilkan CV-nya. Baik, Ibu Dr. Bidan Hajah Evi Nurrahma, Sarjana Sains Terapan Magister Kesehatan, akan membawakan topik Digital Technologies Enhance Lactation Management by Providing Personalized Support Through Application and Telelactation Services. Apakah Ibu Evi Nurrahma sudah hadir?
Yang share screen siapa ya?
Ya, Bu.
Yang share screen-nya dari mana ini? Saya atau Bu Hera?
Kayaknya dari rekan-rekan, dari Ibu sendiri. Rekan panitia mengkonfirmasi Ibu yang akan share screen. Rekan-rekan sekalian, kami berterima kasih jika rekan sekalian masih menyaksikan untuk narasumber kita yang ketiga, yang mana tema yang akan dibawakan juga sangat menarik ya, mengenai penggunaan teknologi digital di dalam meningkatkan pengelolaan laktasi yang secara spesifik akan ditujukan pada telelactation. Ya, suaranya bocor, panitia?
Sama
dari Ibu. Jadi rekan-rekan sekalian tentunya sudah mengenali dengan yang namanya telehealth atau penggunaan pelayanan jarak jauh dalam bidang kesehatan. Kita sudah sering mendengar yang namanya telemedicine, telenursing, dan sekarang ada telelactation. Bagaimana sebetulnya telelactation ini atau laktasi dari jarak jauh ini dapat diterapkan di praktek keperawatan atau asuhan kebidanan pada perempuan di Indonesia. Dan yang akan membawakan adalah narasumber kita yang sangat hebat. Beliau adalah dosen di Poltekkes Kesehatan, Kementerian Kesehatan Kalimantan Timur, yaitu Ibu Dr. Bidan Hajah Evi Nurrahma, Sarjana Sains Terapan Magister Kesehatan. Apakah Ibu Evi sudah siap? Boleh dibuka? Siap. Ya, baik, sudah terdengar baik. Ibu. Ya, silakan Ibu, saya serahkan kepada Ibu Evi.
Halo, good morning. Halo?
Iya Ibu silakan, terdengar Ibu, terdengar dengan sangat jelas.
Terdengar ya?
Ya.
Oh,
silakan.
Okay. My name is Evi. I work in Poltekkes, Kaltim, and I have two sons. The first son, the bigger one, is working ICLM Hospital, and the second son, Dr. Sudhadi Joy, is working in Hermin Hospital, and my husband work in living contractor. Okay. Dikit langsung ya. Materinya. Dengar nggak ya? I'm sorry, this is materi is combined Prof. Diana and Dr. Sri Devi. This tool, which include mobile apps and iDrive platform, can improve breastfeed, increase exclusive breastfeeding rates, and boost maternal knowledge. Key implementation strategies involve using communication platform like WhatsApp for support group employers, track and feature, and library notice consultation to overcome the benefit. What's that?
Ibu Evi?
Ini yang
Yes, we cannot hear you. Suaranya nggak ada Bu tadi. Apakah ada masalah? Baik, akan dibantu panitia Bu.
Okay. This tool, which include mobile apps and iDrive platform, can improve breastfeeding technique, increase inclusive breastfeeding rates, and boost maternal knowledge. Key implementation strategies involve using communication platform like WhatsApp for support group, employee tracking, teach, and delivering notice, consultation to overcome geographic barrier. Implementation, number one, to provide nutrition and protection to the newborn. Second, it induces period of infertility which serves to provide the optimal birth spacing for survival of the offspring. and then exclusive breastfeeding, infant receive only breast milk without any additional food or water or other fluid, with the exception of it vitamin and medicine IV recommended during the first 6 months of life. Meaning of lactation. Lactation is the secretion of milk by the breast. It is thought to be brought about by interaction of progesterone, estrogen, prolactin, and oxytocin within the first month of gestation. Okay. This is a picture lactation expanding, breastfeeding, support of fetal care. And this is the mom calling with telecommunication with consultant, and then his mom and with the baby with WhatsApp to communication with WhatsApp calling, and the family consultation, my mom and my father and the baby. Example use platform that provides video consultation with certified lactation consultant. For example, an article mentioned that mother who receive telemedicine support taught at head likely higher breastfeeding rates than those with online service like mic and lactation and infant feeding or fetal consultation with IBCLCS, VIE, video from home advantage can be done from home or remote without having to go to a clinic. Flexible timing, including evening or when the baby needs to feed urgently, expand the access to mother. Have difficult visiting a consultant in person thing to consult video and audio connection quality and effectiveness. Some mother feel less comfortable interrupting virtual and any person. Benefit of digital technology, one, easy and free access to information. Mother can access breastfeeding guide, education video, breastfeeding position, taste, and solution to common problems such as sore nipple, difficult etc. For example, apps like Lakes, EBHIC, and Middle Family provide information based on the baby's age, mother condition. To breastfeeding factor EPP, fabric code, breastfeeding time and duration, less breath use, breastfeeding frequency, babies, urination, defecation, like etc. Benefit, help mother and health care provide monitor the baby growth and eating pattern. Provide notification or remind for the next breastfeeding time. 3. Remote consultation service. Lactation consult with a lactation consultant via video call, chat, or voice call. Sustainable for mother who live from heart facilities or have limited time. Rather to encourage the success of exclusive breastfeeding if done actively and on a schedule based on several international studies. For interactive and visual education, videos, animation, infographic, and breastfeeding position simulation make it easy to understand for new mother or their with limited literacy skill can be accessed anytime, anywhere, according to the mother need. By monitoring and evaluation by hard work, data from the EPP can be shared with midwife, doctor, or lactation consultant for further analysis. Facilitate remote follow-up, improve efficiency in service, and integrate health post community, health center, or lactation clinic. Seek encourage family involved, EPP of digital media, and all be accessed by husband, family member. Increase emotional support and the family active role in successful breastfeeding. Reduce access inequality, helping mother in remote area, those working or those with a limited. Mobile still receive attention, education, and support. Technologies such as WhatsApp or group telehealth or chatbot can also be used and aided with limited text capabilities. And then this is the technical breastfeeding example of use. Video education has been shown to increase breastfeeding, self-efficacy, confidence of mother breastfeeding in one study, Journal of the Semarang Minister of Health Poltekkes. Not something to consider, mother might be hesitant to take upload personal image or video precise image. Video quality, lighting, angle is important for accurate analysis. Tools like this are still underdeveloped and do not completely replace in-person consultation. Several research journals discuss the use of digital application and service in lactation management, breastfeeding, or lactation. One, the effective of digital application in increasing the success of exclusive breastfeeding, and then not one effective in improving knowledge. There is not necessary strong that on long tunnel check in breastfeeding we have in this review. Relevant provides local Indonesian that digital application can be part of a lactation support strategy. To the use of an experience with lactation among rural breastfeeding mothers, secondary analysis, referendum control trial. How publish the experience. Many did not use the cows and did not experience breastfeeding problem, were uncomfortable with video call or were too basic. Not this study look. And then the experience many did not use because they did. So this is picture technology digital, aplikasi digital, edit lactation APPs, and two lactation service feature. The best way is to let it thaw overnight in the refrigerator. Also, the breeze might back in warm water until it reaches the desired temperature. Do not use microwave or boiling, as this can destroy the nutrient in the breast milk. Once the breast milk has thawed, cycle gently and give it to your baby immediately or store in at room temperature for up to 2 hours. But before live video consultation, mother can demonstrate breastfeeding position let's issue also there is no lactation consultant via video call. The consultant can provide real-time feedback and facial media to chat and instant message. Some platform it text or image message to lactation consultant for patient or update. Flexible schedule. This is schedule appointment based on Monday available after the cloud outside of traditional business hours. Access to certificate lactation consultant and can connect with international certified lactation consultant IBCLCS within their experience. Benefit of the lactation is overcoming geography. 3. Provide access to lactation expertise wherever their mothers ongoing follow-up facilities, follow-up upon to monitor progress and adjust care plan. Privacy and confidence. Mother can receive support in the comfort and the privacy cloud. The one home which is very important in the early day after delivery. Time efficiency. Save the time and effort required to travel to clinic. The combination implementation EBPS and telemedicine service creates a robot support ecosystem for breastfeeding mothers with easy access to personalized information and remote expert consultation. Digital technology not only simplifies lactation management but also empower mother to breast more confident and successful. Okay, thanks. Communication.
Ya, baik. Terima kasih Ibu Dr. Bidan Evi Nurrahma, Sarjana Sentrapan Magister Kesehatan yang sudah memaparkan topik yang sangat menarik dan saya yakin bahwa audiens sekalian, baik rekan-rekan bidan, perawat, gizi, promkes maupun TLM ya, akan sangat memahami bagaimana topik ini kemudian dapat diterapkan di tatanan pelayanan kita. Dan beberapa audiens mungkin memiliki beberapa pertanyaan kepada narasumber dan kami persilahkan kepada rekan-rekan untuk membuka mic-nya dan mulai mengajukan pertanyaan. Silakan.
Okay, good morning. Let me introduce myself. My name is Vira Wadani. I come from Health Poltekkes Ministry of Health, East Kalimantan in Indonesia. Okay, let me ask with you, ma'am. I think this relocation model and consultation, lactation via WhatsApp is new in Indonesia. Ma'am, maybe you have a trick for us as a medical student to implementing this model in citizen of Indonesia. And if there are any challenge throughout implementing this, could you give us a solution? Okay, maybe only this.
Baik, pertanyaannya adalah karena ini adalah suatu hal yang baru, telelaktasi, maka apakah Ibu narasumber memiliki tips dan trik gitu, bagaimana cara melaksanakannya agar efektif dan efisien? Silakan Ibu.
Okay, thanks. Thanks your question. Use WhatsApp and interactive platform disseminate education material, share short video, infographic, and fact sheet about breastfeeding technique and benefit, host Q&A session, health worker or trainer, peer counselor, and answer question real time, encourage peer learning, mother can personal experience, challenge, solution, normalization, strength, and success story, and integrate expert guidance and successful implementation involve moderation of facilitation by head professional, midwife, lactation consultant, or nurse, and guide discussion and correct information, and period live chat or voice session can be scheduled for specific topic dealing with now. Need be understand?
Baik, apakah penanya sudah memahami jawaban dari narasumber? Do you understand about the answer from our speaker? Or do you still want to continue your question? No? Okay, thank you for your question. And next, we open another opportunity for our audience to ask to Dr. Evi Nurrahma. If you want to ask question, please open up your mic and ask to Dr. Evi. Silakan. Do we have another? Okay, Dian Ektasari, please open your mic and ask a question to our speaker. Thank you.
Thank you very much for the time, Dr. Avi. I have one question that I have been curious about. What kind of indicators or data collection method will best show that telelactation is truly helping mothers and baby in Indonesia? Is there some kinds of evaluations, or you already have some data that can be proven that telelactations can be implemented and have higher success in Indonesia?
Okay, thanks. The telemedicine service with remote lactation consultation, telemedicine allow mother to
Telelactation.
consult with a certified lactation consultant via video call or phone call without having to leave their home. This experience live video consultant. Mothers can demonstrate breastfeeding position. Let's issue also there is to lactation consultant via video, chat, and instant message. Some prefer after the ability to text or email message to lactation consultant for question or update. Flexible schedule, easy schedule upon based to the mother, but often include outside of traditional business. Oh. And benefit of the lactation service is overcoming geography very wide access to lactation expert wherever the mother annual follow up facilities, follow point to monitor progress and adjust care plan, revise and confine. Mother can receive support in the comfort and the place of their own home, which especially important in the early day after delivery and time efficiency. Save the time and effort required to travel to clinic. Platform to provide video consultation with certified lactation consultant, for example, ethical mentioned, and mother for receipt. Online service like mark, lactation, and infant feeding after video consultation, with IBLCs via video can be done from home around without having to go to clinic. Flexible timing, including evening or when the baby need to feed urgently. Expanding access to mother who have difficulty sitting and consultant in person. Thing to consider. Video and audio connection quality effects. Some mother feel less comfortable interacting virtual than in person. And benefit of digital technology, number one, easy and fast access to information. Mother can access breastfeeding by educational video, breastfeeding position tips and solution to common problems such as nipple difficulties, its questionable lips like age and middle family provide information based on the baby's age and the mother condition. And breastfeeding tracker EBP helps record breastfeeding time, duration, last breast use, breastfeeding frequency, baby's urination defecation rate, benefits help mother and child provide monitor their baby growth and eating pattern. Provide notification or remind for the next breastfeeding time. Okay.
Okay, I understand. Thank you so much, Dr. Ivy. I think what you're trying to say is that there are a lot of benefits in implementing telelactation, so there are huge success possibility in implementing it. Thank you very much.
That's it.
Okay. Thank you for our audiences who already has question for Dr. Effie as our third speaker, and because of limiting time we have, kita sudahi dulu untuk sesi pertama pada International Conference kita, dan saya serahkan kepada narasumber kita ini sertifikat sebagai pembicara yang akan ditampilkan oleh rekan panitia. Dengan ini kami serahkan sertifikat kepada narasumber ketiga kita, Dr. Bidan Evi Nurrahma, Sarjana Sains Terapan Magister Kesehatan. Terima kasih Bu Evi. Ya, baik rekan-rekan sekalian, untuk selanjutnya kita akan menyerahkan acara kepada MC kita, dan kami berharap bahwa beberapa speaker yang telah ditampilkan pada sesi pertama dapat memberikan insight dan perspektif yang lebih luas kepada rekan-rekan baik tenaga kesehatan maupun rekan-rekan mahasiswa yang haus akan ilmu yang selalu terupdate di dalam acara tahunan kami di ICLM dan juga EBHIC. Saya kembalikan kepada MC Mbak Dita. Thank you Mbak Dita.
Okay, thank you to Miss Era for leading the first session for this seminar international on digital transformation for global health. Okay, we would like to express our sincere appreciation to our moderator, Mrs. Era, for leading the first discussion session, and to all the participants. We will now take a short break and reconvene in this Zoom room at 1 p.m. for the second discussion. Thank you. to the next session, we are going to present some poster from our attendee. We will explore a series of fascinating scientific poster created by our talented presenters. Each poster highlight innovative ideas, original research, and creative solution to real-world problem. The poster will be shown through a slideshow. Without further ado, let us begin poster presentation session, and please enjoy and appreciate the creative research from our poster participant. The title is Comparison of the Effect of Soy Milk and Red Guava Juice on Reducing Fasting Blood Sugar, Total Cholesterol and Blood Pressure in Patients with Metabolic Syndrome from Kurniati Dwi Utami, Dian Christian Sauran, and Liana. Okay, and the next poster is about care movement stunting from Bidan Ega Ersha Urnia Mkes, Bidan Rosalin Arifa Putri, and Bidan Hajar Hamawati Wahyuni. Okay, very interesting studies so far. Congratulations to all poster attendees for their hard work and contribution to scientific knowledge. We also thank our reviewers, audience, and organizing committee for making this session possible. We hope you found this presentation inspiring and insightful. Okay, now we are going to continue with the second discussion session of today's seminar. We would like to invite our moderator to lead the second discussion session. Please welcome Dia Ulfa Hidayati, Magister of Midwifery. Hello, Miss Dia.
Hello, Miss Dita. How are you?
I'm fine, very well, thank you. And then, are you ready to lead the second session for today?
Yes, of course.
Okay, all right, please welcome Miss Dia. The time is yours.
Thank you, Miss Dita. Hello, good afternoon, ladies and gentlemen. I am Dia Ulfa as the moderator for this session. I am really pleased to have you here, and thank you for stay on in Zoom meeting and live streaming YouTube from this morning until this afternoon. Okay, for this session, I would like to have two speakers. And please give me time for introduce our first speakers. He is Mr. Debi Syahrul Ramadan, PhD. He is an assistant professor in Faculty of Nursing, Chulalongkorn University, Bangkok, Thailand. He has received his bachelor degree in School of Nursing, Malang State Health Polytechnic. And he has taken his master degree in Master of Health Science in Airlangga University and Master Science in Nursing in Taipei Medical University. And he is received his doctoral degree in Taipei Medical University. He has professional license, diabetes educator specialist, and International Diabetes Federation, and certificate in International Diabetes Federation. Okay, we already have Mr. Debi Syahrul Ramadan, PhD here. Hello, Mr. Debi.
Hello, Sawadika. Good afternoon. Yeah.
Good afternoon. How are you, Mr. Debi?
I'm great. Thank you so much for inviting me.
Okay, I am Dia as your moderator today. Okay, I am really pleased to have you here, and yeah, for this session, we will have a 3 part of this session. The first is time for you to present your materials, and then after that, we have a question and answer session, and followed by the conclusion. So we have 1 hour for you to deliver your materials. The time is yours, Mr. Debi.
Okay, thank you so much, Miss Dia, right?
Yeah.
Miss Dia for explaining and introducing me. And first of all, thank you very much for the East Kalimantan Health Polytechnic for inviting me in the great event, East Borneo, right? East Borneo International Conference and International Conference on Lactation Management as well. And today I would like to discuss to all of you about the diabetes management in digital era. Let me share my PowerPoint. Could you see everyone to see my PowerPoint, right? So it's clear? Hello, Miss Dia, it's clear?
It's clear. How about the participant?
It's okay?
You already seen the materials from Mr. Debi? Yeah, it's clear, Mr. Debi.
Okay, thank you very much. And okay, because we have only 1 hour, so I have to start and discuss with all of you about the role of diabetes educator in the digital age, empowering patients through technology. And in the last section, I would like to introduce to all of you about the new type of diabetes. So because the new type, which is the type 5 diabetes, because the IDF or International Diabetes Federation have introduced this new type this year on April when I have attended the Congress, a diabetes Congress by IDF in Bangkok, Thailand. And first of all, I would like to remind to all of you, if everyone here or if participant here have an interest in diabetes management, I think you have to update the knowledge by reading the 11th edition of Diabetes Atlas. You can get for free. You can check out for free in the internet or in the Google. Just download. This is the latest one from the Diabetes Atlas from International Diabetes Federations. I think this is a really good guideline if you want to do research or community empowerment or even diabetes education in the community or in the clinic or in the hospital. You can read by yourself about this guideline. And let's move to the diabetes prevalence. That this also I got this data from the 11th edition of Diabetes Atlas, that we have to really take a note that diabetes is major health issue that has reached alarming level. The 11th edition confirmed that diabetes is one of various growing global health emergencies of the 21st century. And when you have noticed that in the live picture that around the world or even in each region like Europe, North America, and we can look up in Southeast Asia, is the diabetes prevalence from 2024 until 2025 is dramatically increasing around 73% in Southeast Asia. Is so significant. And all over region around the world also have increased significantly. I think most of them is more than 40%. So it's mean diabetes is still a major health issue in this era. And let's move to the number of world standardized prevalence of diabetes in adult 20 until 79 years in the world and in the IDF regions. And we have to understand that from all type of diabetes, type 2 diabetes is the most common type of diabetes, accounting for over 90% of all diabetes worldwide. So that's why in Indonesia as well, we I think the diabetes educator or the healthcare professional, we noticed that most of diabetes case in Indonesia also type 2 diabetes. So it's type 2 diabetes. I will talk about the different type of diabetes in the following slides. It's mainly is about the lifestyle, right? So that's why diabetes education right now is really crucial. And let's move to the top 10 countries or territories by number of adult 20 until 79 years with diabetes in 2024 and 2050. And Indonesia still top 5. So I think as a healthcare professional, doctor, nurse, clinician, pharmacist, also midwifery, we have to really understand that Indonesia in the following years still top 5. They predict still top 5 for the diabetes case. And the current realities, we have to know that the global prevalence of diabetes continues to rise, like I mentioned before, that especially in low and middle income countries. If you still remember, in South Asia increased 73%. That's and most of the countries in Southeast Asia is low middle country, right? And access to ongoing diabetes education is limited in many areas, and where a lot of recent study as well reported that access to ongoing diabetes education is still a difficulty for the patient with diabetes who living in countryside as well. And many patients still lack consistent DCMES support, leading to poor outcomes. Let me explain what is DCMES in the following slide. And the last current reality is that we have to take note that adherence to medication, diet, and exercise remains optimal as well. So maybe if the participant here working in the clinical setting, like working in the puskesmas or primary healthcare setting in Indonesia, actually the patient adherence is hard, right? Sometimes they forgot or feel boring or feel fatigued to control their blood glucose level, and as well as to take the medication in the clinics or in the primary healthcare. So it's kind of issue that we faced in the current realities. And this is the summary of the differences, the traditional challenges and the digital solution. And for the first one, we have to know that the traditional challenges, we have limited access to the time, distance, and cost as well. And in the 10 years ago as well, the diabetes educators, the diabetes education still static and one-way education as well, a passive patient, and shortage of diabetes educators. And we have to know right now, recent study provided digital solution such as the mobile application and telemedicine or telehealth and online learning platform, interactive tool, video, even game learning as well. And right now, instead of participation, the digital as well, we have to empower users to track the site and self-monitor. And the last issue that we have to know about digital solution is the scalable digital programs and peer support communities as well. And I have to remind to all of you that technology is not here to replace nurse or diabetes educators, but is here to amplify their reach and deepen their impact. So that's why right now we need to digital transformation in terms of diabetes education or diabetes management in patients with diabetes. And let's move to the another guideline from I think this is the quite important guideline from the ETA or American Diabetes Education and the Association of Diabetes Care and Education Specialists, or it's called ADCES, have been provided 3 types of diabetes self-management programs. The first one is DCME or Diabetes Self-Management Education. The second one is DCMS or Diabetes Self-Management Support. And the last one, or the updated one, is Diabetes Self-Management Education and Support, or it's called DCMES. I think for those 3, we can check out for free in the Google or in the internet. And this is the guideline that you have to read if you wanted to research about diabetes management or diabetes education, or if you want to some arrange some education in primary healthcare. I think you have to read and understand what kind of diabetes self-management education and support. And actually, the record from the 2011 about the DCME, and then the record DCMES in 2014. And they produced also 2017 about the national standard for diabetes education and support. And this one also the quite new one from they have provided the new one, the 2023 National Standard for Diabetes Self-Management and Education and Support. And personally, I would like to suggest you to read this one because I think this is a most comprehensive one, and the latest one they revise every, I think it's 3 years or 4 years. They have published the new guideline from the ADA. I think it's quite important if you are in diabetes educator to read this guideline for now. And as I mentioned in early slide that I mentioned about DCMES, right? Let me explain about DCMES. And DCMES is the ongoing process of facilitating the knowledge, skill, and abilities necessary for diabetes self-care, involving educational and supportive intervention to assist people with diabetes in managing their condition. And I think it maybe if you newbie in the diabetes education, maybe it's quite new and you have to learn step by step, but slowly about DCMES, because the concept of DCMES I think is quite a comprehensive one. But the main point of DCMES is the ongoing process. So maybe in the previous 10 or 15 years ago, when we provide a diabetes education just one time or 2 times in the primary healthcare, but for now, the diabetes guideline, you have to understand about the ongoing process, because ongoing process is really crucial for managing their condition. So you have to make sure that the patient with diabetes have good enough knowledge and good enough skill and ability as well to maintain their daily life. So that's why the concept of DCMES is important. And in the concept of DCMES, there are some the core domain of DCMES, and they call it based on ADCES 7 self-care behavior. The concept of ADCES 7 self-care behavior into the I think it is instead of DCMES as well. And you have to remember that those 7 self-care behavior is quite matters for diabetes in managing a patient with diabetes. And the first one is healthy eating. Of course, everybody know here, I think, really understand about healthy eating, being active or physical activity, and monitoring as well, especially blood glucose and taking medication. So that's why adherence of patient is matter as well. And another 3 term, and you have to really understand about the problem solving, healthy coping, and reducing risk about the food care or screening, because right now we have a limited time. I think I would like to suggest you to all of you here to read the guideline and to read those last three concept about problem solving, healthy coping, and reducing risks. I think as a diabetes educator or diabetes researcher, we will really understand what kind of the definition of problem solving, healthy coping, and reducing risk about the complication as well. And this is the summary of DCMES. Maybe is too easy to understand about the DCMS is from the clinical knowledge, and we have to as well to add the behavioral support and ongoing follow-up as well. But the concept I always remind to all diabetes at court about the ongoing follow-up, because the ongoing follow-up is really important. So as a healthcare professional or healthcare provider, if you have a diabetes education program in your place, so you have to remember what kind of action or program to increase the ongoing follow-up in patient with diabetes. That's matter. And why is DCMES so important? So this is I did summary from the studies, from the recent study, that without DCMES and with DCMES, and you have to know that with DCMES, the patient feel overwhelmed or misinformed, and with DCMES, the patient are confident, informed, and empowered, because the DC when we delivering comprehensive DCMES with the 7 self-care behavior concept, of course, the patient will increase the knowledge, skill, and also they feel confident to manage the diabetes in their daily life. And as well, some of recent study have reported about poor medication adherence for not attending DCMS, and also risk of complication increases as well, and one size fits all approach. And with DCMES, that's improve adherence and lifestyle consistency. And I think that the third is very important. It's about reducing SpA1C by 1 and until 2%. And the last one is personalized goal setting and progress tracking as well. Let me explain about my recent paper about the comparative effect of diabetes self-management programs on type 2 diabetes clinical outcomes. I did this study by systematic review and network meta-analysis, and this project has been published in 2024 in the Diabetes Metabolism Research and Review. This is a tier 1 journal. And if you still remember, in the previous slide that I mentioned 3 concepts, right, about DCMES, DCMS, and DCME. And actually in this project, basically I have to compare about those 3, and also with the reference comparison with usual care. And the definition of usual care is the patient or the participant just visiting visiting a clinic or hospital routinely to meet face-to-face with healthcare professional and discuss diabetes management. That's the definition of usual care. And this project, I did comparison between these 4 type of interventions. And let's move to the figure 1. Maybe if everyone, if you do not really well understand about network meta-analysis, it's called the network plot. So network plot is the summary how many studies will include in these projects. For example, like the figure A, right? The figure A is the network plot of diabetes self-management program for managing diabetes clinical outcome. A is SpA1C. So the outcome of figure A is SpA1C, and the figure B is fasting blood glucose. C is total cholesterol, D is systolic blood pressure, and E diastolic blood pressure. So our project has 5 the outcomes, but the primary outcome is SpA1C or classical hemoglobin. For example, like in this project, we have like 45 studies, comparison between DCMES with usual care, and 1 studies DCME comparison DCMES, and 10 10 studies did comparison DCMES with DCME, and 39 studies did comparison DCME and UC or usual care. So this is the kind of summary how many studies have included in the projects. And you know, the dot for UC is larger than another, right? But it's mean that a larger the participant is huge, so it's more large toward picture. It's mean the study have a lot of participants. And let me explain briefly about the main outcome of this project. So you have to still remember that I did comparison for intervention, right? DCME. Reduce as SPA1C significantly is around the 0.90% is significant with comparison with UC. So, and also DCMS also significantly, DCME also significantly as well in reducing SPA1C. However, DCME is still higher the number, right? 0.69. So from this study, this study is stronger about the guideline that we have to right now. We have to deliver DCMS or ongoing follow-up to the patients if we want to improving SPA1C as a primary things in managing type 2 in managing patient with diabetes. So everyone here, we have to know about the DCME, the concept, DCMES concept as well. And from my projects, the DCMES in people with type 2 diabetes yield the greatest improvement in the key clinical outcome of SPA1C, fasting blood glucose and blood pressure level. And based on the evidence, we highly recommend the integration of DCMES approach in the design and delivery of diabetes self-management program. And we strongly advocate for its implementation in clinical practice to enhance diabetes management and promote better health outcome for people with type 2 diabetes. And after knowing about the concept of diabetes education, which is DCMES, let's move to the what is the diabetes educator. So, and what kind of responsibility have to from the diabetes educator. So this is the what responsibility does diabetes educator have. So I always remind to my college mate who interested in diabetes management that the multidisciplinary team with interdisciplinary role is crucial. So that's why in diabetes management or in diabetes education, we cannot focus on one profession like physician. All professions such as physician, nurses, and health educator, dietitian, psychologists, and people and families, all that matters. So there's a multidisciplinary team including diverse healthcare professional provide diabetes education, care, and treatment. And it is the responsibility of all healthcare professionals to acquire the knowledge, skill, and competency to provide evidence-based high-quality diabetes educations. So we have to collaborate, and collaboration is matter in diabetes education or even in diabetes management as well. And almost 100% of care in diabetes is conducted by people with diabetes and not by healthcare professional. And a stepwise process comprising of an organized set of activities help people with diabetes and their family or caregivers to understand the disease and treatment, to collaborate in care and to take responsibility of their health. So that's why right now one of good study have reported key competency for effective diabetes care, which is information training, awareness, and social and psychological support. Therefore, the healthcare professional must develop diabetes knowledge and skill and establish positive relationship with people with diabetes and their families. And this is, I think, also the skill that we have to understand as a diabetes educator, that effective communication among team members and respect for expertise of all of the team members, and open discussion. Of course, open discussion is really important in diabetes educations regarding management, decision making, problem solving, and setting priorities with diabetes, and a collaborative approach to pursuit of program goal and outcome. As I mentioned before, that multidisciplinary team uh, is great. And this is the basic knowledge, the role of diabetes educator. We have three. The first one is to enable people with diabetes to manage their health to best to their ability. So as a diabetes educator or healthcare provider who working in the primary health or even in the hospital. So if you have the most of the patient with diabetes in your place, I think the main goal, you have to make sure that your patient can manage their diabetes in their life, in their daily life by themselves confidently. So that's why one of the important role of diabetes educator is to enable patient with diabetes to manage their health to the best of their ability. And the second one is to allow them to make able choices and take action, but based on informed judgment, and to enhance the quality of life of the person with diabetes. So that's why diabetes educator are integral part of the diabetes management team. And also the communication skill is matter as well for the diabetes educator. So you can read by yourself, but like empathy, active listening as well, and the most important also encourage and reinforce positively for the patient. I think this also important in, the communication as well if you have diabetes educator here. And if you still remember the Albert Bandura theory, I think this quite maybe it's old theory, because the Albert Bandura theory or social learning theory Bandura has been published in 1977. However, personally, I'm still sometimes use this concept in diabetes educations, because the Albert Bandura theory, as personal in my opinion, is quite good as well, because in Albert Bandura theory we have like three concepts: the behavior, personal factors, and environmental factors. Also in the Albert Bandura theory, they have the application in people with diabetes, like the concept of sharing experience. I think right now is still a matters, and diabetes acceptance, especially for new diagnosis, especially diabetes. I think diabetes acceptance concept, I think we have to educate about diabetes acceptance into the patient, especially the new diagnosis the patients. And autonomy in diabetes management and development of skill and well-being as well. Well-being, of course, the main goal of everything in diabetes management. So that's why sometimes when we do research or education, sometimes we use this concept, but you can use another concept as well. I think it's based on your interest, or pen as your topic of your research, or pen as your topic of your program of your education as well. And the next one is the important evidence-based care about the uh, healthcare professionals should be able to assess and review relevant literature, including guideline and protocol, to find out what has already been said about an issue. And the second one is the healthcare professional, especially diabetes care, you have to determine whether the finding or recommendation related to their area of practice and can thus be implemented. So that's why the evidence-based care recently is matter. And according to the evidence-based care, research is an essential aspect of the diabetes healthcare professional role. So that's why I always remind to my friends as well, when you got a problem in your clinics or in the primary healthcare, you have to do review, and you have to read the paper according to your problem. That's why you cannot say that based on experience or based on someone said. So you have to looking up about the updated guideline. That's evidence-based care. And from this conference, I would like to maybe it's like explaining, because this right now I did the program about the diabetes educator for 5.0. 5.0 is the digital era, but my research still ongoing. So maybe in the end of this year, I will submit this program. So basically, the diabetes educator 5.0 as a in the role of the diabetes educator in the digital era or digital transformation. This is the 5 important concept that we have to put in ourselves as diabetes educator. The first one is evidence-based care, and the second one is technology empower and emotional intelligent, patient center, and the last one is social responsible. Let me explain briefly for each one skill for diabetes educator. The first one is evidence-based. As I mentioned, that grounded in current scientific research and clinical guideline is matter. So you have to read, you have to update your knowledge is matter. And uses proven educational strategies, validated tools, and outcome-driven intervention, and ensure that digital innovation are supported by data, not just trends. So that I mentioned before, you have to read the guideline or data or update the research to improve your knowledge and solve your problem in your place. And technology empower, competent in using the platform application and telehealth tools to deliver care education, translate complex data from continuous glucose monitor health application or digital dashboard into actionable advice, and embraces innovation but remains adaptable to patient with limited digital access. And the third one is emotional intelligence. So we have to demonstrate empathy, active listening, and compassion even through a screen. And understanding about how emotion affect diabetes management and staff behavior is important. Most of the recent study have reported the mental health of patients with diabetes. So that's why, especially for nurse and we have like mental health a diagnosis regarding to mental health as well, right? So that's why when you look up the patient in the primary healthcare, we have to focus as well about their symptom, their emotional, their mental health as well, because the diabetes disease is a long chronic disease, and they have to manage their life in daily life for long. So that's why you have to make sure their mental health and emotional is good. So that's why uh, understand how emotion from the patient is important as a diabetes educator, and the balanced clinical accuracy with human sensitivity. And the fourth is about patient center. The concept of patient center is recognize that every patient needs, culture, and context are unique, and encourage shared decision making and respect patient voices, and design education that fit the patient lifestyle, not the other way around. And the last one is socially responsible and aware of the broader determinant of health like poverty, nutrition, education, and inequality as well, and advocate for equity in diabetes profession and care, including under recognized from like type 5 diabetes. The main one of the main reasons that I did the program about diabetes 5.0 is because this year the idea of just publishing about the type 5 diabetes is about the malnutrition. So that's why as a diabetic as well, we have to know the issue from the social about the poverty, undernutrition, or lack of nutrition from the community as well. So this kind of important thing we have to know in this era, and we can use technology as well to close the gaps. The most important is to close the gaps, not only to widen them about technology. Let's move to the important part about technology and diabetes educations. And this is the I think right now, if you're talking about digital tools or digital intervention in diabetes management, a lot of studies already. And we have like mobile application and device as well. Telemedicine, most of the recent study also reported the impact of telehealth or telemedicine, and chatbot or AI coach. Right now we have ChatGPT. I think everyone, especially young generations or even not young generation, when you look at problem, you just type in ChatGPT, right? So that's why ChatGPT I think is one important thing as well. If you want to do some information, but you have to take carefully as well. We got information from ChatGPT, and online peer support. I think right now most of the social media forums such as social media or a digital platform, they created about the online peer support. I think this is quite good as well, because as mentioned before that peer support in diabetes management, most of recent study have reported the positive impact of the peer support. So that's why this kind of thing about the online peer support still matter in digital tools and social media as well. Right now, especially young generation, when you have the like Facebook, TikTok, or Instagram as well. Right now, I think most of diabetes, not some of diabetes educator using social media to increase diabetes knowledge. I think personally this is really good, because or I think around the world right now they use the Instagram or TikTok or Facebook. So that's why as a diabetes expert you have to think what kind of social media is great to deliver your idea in diabetes educations. So that's why this is also my on platform as well. I created with my team. It's called Diabetes Evidence Platform in Instagram. So I think if you interest about diabetes knowledge or recent diabetes studies, you can follow in Diabetes Evidence. I think this is I have created when I was study PhD in Taiwan, so that's why I have to give something using as the social media platform. So that's why the main reason why I have to create this platform, because when I was a PhD and doing project about diabetes management, sometimes the community and especially young generation, when they use social media, some of them they got the misinformation about diabetes management. So that's why I namely evident, because when I provide this content into the patients, so I always put in the below of the content about the evidence or the paper that reported this evidence. So that's why as a diabetes doctor, I have responsibility to provide the good evidence to the patient with diabetes, or not only patient but the community, especially we use Instagram. So that's why I got a positive comment as well from someone who followed this project, because I always provide the updated evidence as well. And let's move to my projects who call the comparative efficacy of digitally assisted intervention for improving glycated hemoglobin level among patients with type 2 diabetes, systematic review and component network meta-analysis. My project is published in 2023 in diabetes, obesity, and metabolism. Is different from my previous network, because from this project I evaluated and did comparison what is the most optimal digitally assisted intervention in reducing HbA1c level. And I think this is the type of intervention in this project. So when you look at table 1, I think we have like 17 type of intervention in this project. And for the first 10, they have like mobile application, short message service. In this study also some of study use telephone call and web-based, email, time-based online game, and for 1 until 6 is the digital assisted intervention. However, when we conducted a network meta-analysis, we have to include all of the comparison as well. So that's why we not only focusing on digital, even the main thing is about digitally as an intervention. So that's why for 1 until 6 is focusing on digitally, and 7 is about the professional education program. So we have like self monitoring blood glucose, standard care as well as a reference, and not only single intervention. So I have recruited as well multiple interventions. So in network meta-analysis, we have to include everything and did comparison as well. And for example, in the 10 intervention, right, there is the multiple interventions as mobile application, combining with professional education program and combining as well with peer support education, or it's called PSE. And we still have like 17. For the 11 until 17 is also multiple intervention as well. It's more than one. You can read the definition in the left side, and this is the network plot. So that's why we have like 17 intervention, right? A single intervention and also multiple intervention. So this is, if you still remember, this is the summary of how many participants and how many studies have reported did comparison in this project. For example, like 24 studies have reported comparison mobile application did comparison with standard care, and you as also another one. And this is the main finding of this project. The first one is figure A. The figure A is the forest plot of digitally assisted intervention for managing SPA1C, and figure B is called the component. Because as you still remember that we have like single and multiple intervention. For the traditional network meta-analysis, we find that combining mobile application with professional education program and combining as well with PSC is a most optimal, significantly around 1.98% of SPA1C level. But as a diabetes educator, we have to know, because this is the multiple, we don't know what kind of component is the most optimal in reducing SPA1C level, right? So that's why I have to add another analysis, is called the component. With component network analysis, we have to know what kind of single component which the most optimal in reducing SPA1C level. So that's why when I have added another analysis using the component network meta, it's called the component network meta analysis. So the PSE, actually the most optimal one, can reducing 1.50 in reducing SPA1C level or classic hemoglobin for patients with type 2 diabetes. However, because this project have focusing on digital asset interventions, and we have to the second, third, and the fourth is also significant, and those three is the digitally asset intervention. So that's why the short message service as well as a reminder message still have significant reducing SPA1C level around 0.33. I think it's quite good in SPA1C level. Mobile application is quite similar number with short message service and telephone call as well, still significant in improving SPA1C level. So that's why my project have concluded that the short message service and mobile application are optimal digitally asset intervention for reducing SPA1C level, and diabetes educator can integrate digitally assisted intervention complemented by educational program, particularly mobile application combined with professional education program and PSC into daily care to control SPA1C level. And this slide is the key support role in the CSC ecosystem. I think for right now, we have to know that not only focus on healthcare professional, we have like family members, peer supports or groups, especially type 1 diabetes. So because I have friends who got the type 1 diabetes, so they have like a group WhatsApp groups. I think it's quite positive as well. That's though they can share what kind of the challenges, what kind of the stigma, what kind of the problem they can share and with their mates in the WhatsApp group, because all the groups have type 1 diabetes, so they can give and learn from each other. And community health worker as well, the bridge between clinic at home, cultural translation and monitoring, digital coach, chatbot I mentioned before, so GPT I think is one of solution way, and primary care team such as medication adjustment, lab review, and behavioral counseling as I think is matter as is crucial. And of course in digital education we have like a barriers, so I think for barriers is normal, so we have to know as a healthcare professional and understand what kind of barriers. I did summary from the some of previous study that we have digital literacy gaps, limited access to smartphone or internet, language and cultural mismatch, and information overload, trust and privacy concerns. So those three is okay, I think. However, in digital, of course, I think not only digital education, even in traditional way, we have like barrier, right? So that's why barrier is normal in everything. So I think we have to take note that, understand how to solve that barriers. And another concept that I have to remind to all of you about the personalized concepts. Why a personalization matters in DCMES. So that's why for example, like we have like two patients with diabetes. No two people with diabetes are the same. Even two, they have the different culture of eating habits. They have different learning style. They have different emotional reaction, or even they have different access to technology and support. So that's why when I give diabetes education into patients, so I kind of like uh general to give like general to each to everyone. So that's why sometimes when we want to do some intervention, we have to look up about the and look at back about the personalized concepts, because what each patient have different is unique, especially in patient with diabetes. So that's why they have like different challenges, different problem. So that's why as a healthcare professional, you have to really understand about those concepts. And the traditional DCMES is often one size fit all, maybe like 10 years ago or 15 years ago. And but emergency model now offer adaptive education, DCMES that adjust to your daily use pattern, your goal, and your language and preference as well. And that's why this my project as well. I did personalize diabetes text messaging combined with peer education on patient with type 2 diabetes using randomized control trial. Actually, the research gap or the main reason our team did this project is, but still, if you still remember, the short message service is still is number one, the most optimal digitally assisted intervention in reaching HbA1c level, and also PSE is called peer support education is top one. Even peer support education is not digitally assisted, however, still impressed about the results. So that's why, and no previous study have reported the combining between those between both about the personalized reminders and peer support education. So that's why this project is I did combining about the personalized about diabetes text messaging and combining with peer support education using the concept of personalized. And surprisingly, that the conclusion, the personalized DP text and combining with peer support education is more effective in enhancing clinical outcome, and also reducing fatigue, improving sleep quality, and improving quality of life in patients with type 2 diabetes in comparison with only with a reminder DP text and also professional education programs. So therefore, educators can incorporate personalized DP tech combined with PSC as a component of diabetes educations program that they integrate digital intervention and supplementary programs. And this an example of my personalized DP text. And for the content, actually we have like seven self-care behavior from ADCES. However, for this project, our team have discussed and conclude we use the four important things about health eating, being active, taking medication, and the monitoring blood glucose level. I think you can read for free in the internet, and if you want to interest in my projects about personalized concepts. And this is also, I think in Indonesia, most of patients already start using CGM or continuous glucose monitor or CGM. I think CGM is really have positive impact into the patients, especially patients with type 1 diabetes. And CGM is a wearable medical device that automatically track blood glucose level or sugar level throughout the day and night, so without the need of frequent finger pricks. And the CGM work is, this is the most sensor is placed under the skin, usually on the arm of the abdomen, and the sensor measure glucose level in interstitial fluids, the fluid between cell. It send data every few minutes to a receiver, smartphone, and to smartwatch. So it is connected to smartwatch or your phone. And some CGM provide alert when blood sugar is too high or too low. And this is the differences between CGM and traditional glucometer, right? So I think for the advantages is for the CGM is no finger pricks, and also for the type 1 diabetes, because I did interview for type 1 diabetes for the patient with type 1 diabetes, they feel so glad and happy when using CGM because they can track and connect it with their smartphone or also with their smartwatch. So that's why they can control their blood glucose level. So they early to know what time they got the low blood sugar level, also high blood sugar level. So that's the advantage of digitally about this continuous about the CGM. Also, I picked up one study about the effect of CGM on glycemic control in type 2 diabetes, and for CGM, of course, provide greater benefits in glycemic management compared with the traditional or traditional blood glucose level. And take note that DCMES is essential for empowering people with diabetes. It's not optional, it's a foundational. And the digital tool expand access, improve engagement and personalized care. And the future of diabetes care is personalized, technology enable and people power. And let's explain, because we only have 3 minutes. So I have listed the new type of diabetes, which is the type 5 diabetes. So as I mentioned earlier, that when I've attended as diabetes educator, diabetes IDF senior fellow in Bangkok, so the IDF launched new type 5 diabetes working group as well. So what is the type 5 diabetes? So you know that in the traditional one, we have like 4, right? Type 1, type 2, gestational, and other specific type or diabetes. But recently, the last one is type 5 diabetes. So type 5 diabetes is also known the malnutrition related diabetes mellitus, or is called MRTM. It's from of diabetes that develop in individuals who have experienced long-term protein energy malnutrition, especially during childhood and adolescence. And it's different from type 1 or type 2. This condition arises in underserved population where chronic undernutrition lead to irreversible pancreatic damage and impaired insulin production. Actually, the history of type 5 diabetes that the IDF team or the other expert have did research in Africa especially, and more than 60 years, and they concluded that the chronic malnutrition can impact to the function of the pancreas. So that's why it's called the malnutrition is really bad and can impact the in the pancreas function as well, and especially in beta cell. And this is the comparison between those 5 types. So you can read by yourself because we only have 2 minutes right now. And for type 5 is actually that I mentioned before, the early symptom is the fatigue, thickness, and slow healing wounds that IDF mentioned, that also because they got the malnutrition. So we have to make sure that everyone have good nutrition right now. And public health, and this is about what we can do as a diabetes educator. So we have to raising awareness among healthcare teams and communities, screening undernourished and lean adult presenting with explained hyperglycemia, providing nutrition, focused education integrated with diabetes management, advocating for policies addressing poverty, especially in countryside of Indonesia as well, food security and the early childhood nutrition. And for the research and policy needs regarding to the type of diabetes, I think right now we have to do awareness as well and integration type of diabetes awareness, but also developing the screening tools for type of diabetes for the research context. Therefore, me and my team, this is just published in health education behavior about me and my team have developed, our team have developed about the skill knowledge about type 5 diabetes knowledge skill, especially assessing community knowledge in rural setting. And this is also the final 10 item about the type 5 diabetes knowledge skill. I think if you want to do research about type of diabetes, you can email me or chat me to get this skill if you want to do research about type of diabetes knowledge. And what can family do to prevent type 5 diabetes? So type 5 diabetes is not caused by overeating, but the malnutrition. Therefore, prevention is not about restricting food, but about ensuring that family have access to enough nutrition and balanced meal. I think for the recap, there's the recap that the digital era has to transform how the business care is delivered, but the human connection remains central. And diabetes educator now stand at the intersection of science, technology, and compassion, guiding patients through data, device, and digital platform. And type of diabetes remind us that beyond algorithm and application, millions still face the consequences of hunger and deprivations. And thank you very much for all my presentations, and thank you very much for the for attending this great conference. And I will back my time to the moderator.
Okay, thank you very much, Mr. Devi Shalom Ramadan, for the interesting and informative presentation. Yeah, there are so many evidence from your research about the diabetes, how the educator, how us as the educator to prevent the diabetes. And now we move to the Q&A session. For all participants, if you have any question, please raise hand and open your camera and microphone, please.
Hello. Hey, it's great to talk with you, sir. My name is Najwa Sabila. I'm a nursing student at the Health Poltekkes, Borneo. Firstly, your material and presentation is so clearly, and I barely understand it. Few months ago, I had a neighbor who elderly and have diabetes mellitus type 2. He's elderly people and doesn't have to hope to get well. And we, as a neighbor, give us support and education many times, but he doesn't hear that, as well as he does because the complication. So my question is, are DSMES is effective in elderly people who have a long chronic diabetes mellitus and doesn't have a hope to take care of yourself? And I'm also a nursing student and I want to take a role for this DSMES. What kinda I have to do? Really, it's like this. Thank you, sir.
Thank you so much.
Okay, Mr. Debi, would you like to answer it directly?
Oh, okay. Thank you so much.
Okay.
Thank you so much, Miss Najwa Sabila. Nice to know about you. Nice to meet you virtually. Thank you so much for the compliment. And then actually your question is really, really great because your neighbor, the elderly, right? Who got complication and difficulties to manage the diabetes and also finally they pass. I think I heard that example not first time from you. My friend as well sometimes is in my community in Indonesia. When the person is old or elderly, it's quite difficult to manage their condition. However, the one thing that I have to know about you that when you have the neighbor, you have to the first one is you have to make sure the elderly have the relative or not, they have the family or not, maybe they have son or not, or they live single. If they have, if the elderly with diabetes has a families, you have to make sure and give education to the family as well. Giving of course we have difficulties to give the health education to the family who have the elderly patient. However, you have to take collaboration with the the healthcare professional from the primary healthcare, such as you can invite maybe one nurse or one midwifery from primary healthcare, because you have to remind them that this is quite difficult and we need some professional to remind you and come to their home. We call it home visits as well. And of course, if you're talking about digital issue, it's quite difficult. So that's why the one thing that you have to make sure that the family also they can quite understand about digital education as well. At least like using WhatsApp or reminder text or yes, I think it's quite important as well. And you have to know as well the mental health issue. So they say why one factor can influence the difficulties management in elderly is the mental health as well. So as a nurse student, you have to know the nurse diagnosis also you have included a lot of mental health like fatigue, anxiety and depression as well. So you have to know what kind of factor from the elderly cannot control their diabetes management. And then collaborating that I mentioned is quite important as well. I think those three or those concepts, I think you have to take note if you want to face about the elderly with diabetes. And also the economic, you have to make sure the economic. from the patient. So comprehensive information from the patient is matter before you give the education or manage that patients. Thank you so much. Your question is great.
Okay, thank you, Miss. Is it clear? Yeah, okay, thank you, Mr. Debbie, for the answer. We move to the other question. Is there any question? Yeah, please. Okay, please open your microphone.
Okay. Okay. Good afternoon. Let me introduce myself. My name is Fia Ramadhani. I come from Health Polytechnic, Ministry of Health, East Kalimantan, Indonesia. Okay, sir. Let me ask you. From the explanation above, I heard something called 5.0. So the question is the concept of diabetes educator 5.0 realistically implemented in Indonesia, considering the digital and socio-economic gaps that are still high, especially for remote communities? Okay, maybe this is my question. Thank you so much.
Okay. Thank you so much. Nice to meet you, Via Rahmadani from the midwifery, right? And yes, good question about diabetes educator 5.0. Actually, the concept of diabetes educator 5.0 is for my team and myself. So it's still not been published yet, but it's still ongoing research. However, I got a positive comment from the 20 expert from the 10 countries, including Indonesia. But so that's why this concept is not implemented as well because still ongoing research. However, why I have to present in this great event, because in right now in the almost finished that project, and I got a comment from the 20 IDF expert, so they did agree about this concept, because in the digital area, as a diabetes educator, we have to know the digital, particular digital one. But like you mentioned before, especially in countrysides of, for example, in countries of Indonesia, we have difficulties to receive the digital one, right? However, we still have telemedicine or telehealth. It is okay. Also reminding sites. Of course, however, I can understand that every country, every place, or every countryside have different difficulties to control that condition. However, as a healthcare professional, the first one we have to know what kind of factor why the patient difficulties, or they have done they don't have internet or something, but we have to give a solution such as a telemedicine, or we have to get home visit as well. So that's why the last concept of diabetes educator 5.0 is socially recognized. Why I have put socially recognized? Because as a diabetes educator, we cannot just focus on digital, but we have to focus what kind of the condition in the community. So that's why this is a matter as well. When we know and understand what happened in the social, especially in the countryside, we will think about the better solutions to them. So that's all I can say right now. But thank you so much for addressing the 5.0. I appreciate that. Thank you so much.
Okay, thank you, Miss Fia, for the question, and Mr. Debbie for all the answer of the question. Okay, yeah, thank you very much for giving us the very interesting presentation, like the how we manage the diabetes in 5.0, and how the management of how to manage the diabetes self-management education and the support. How important is the SMES, and you give us so many evidence from your research, and we hope that we can apply it in our place. Yeah. Okay, by the end of this time, allow me to give you the certificate, the virtual certificate. Mr. Devi, thank you very much. Hope we can have another international conference, and hope you will be our speakers again. Okay, thank you very much, Mr.
very much,
Devi.
Miss
สวัสดี
Dia.
ค่ะ ขอบคุณค่ะ
Yeah, kapung kap.
Okay, this is the end of the first speakers, and then we move to our second speakers for this session, and we will have Dr. Nustini Eskap Mkap as our second speaker. She is a lecturer in East Kalimantan Health Polytechnic, and she has received her bachelor degree in Brawijaya University, and then for master degree in Brawijaya University too, and then for the doctoral degree, he is received his doctoral degree in Hasanuddin University Makassar, and then her professional area is in community nursing. Okay, Ms. Tini, have you already joined us in the Zoom? Okay, maybe we can wait a little bit time for Ms. Tini. Okay, Ms. Tini will give a presentation about the prevention of diabetes foot disease through the community empowerment in the digital era. And please wait a few minutes for Ms. Tini to join us in the Zoom meeting. Okay, for all participants, please stay on in the Zoom because this is a really good and interesting topic. And this is sometimes be the one of the complication for diabetes patient in the community. Okay, we already have Miss Tini here. Hello, Miss Tini. Okay, welcome, Miss Tini. Miss Tini, I think your microphone is still mute. Okay, please wait a few minutes.
Oh ya. Oke,
Okay,
yes.
Miss Tini is
Ulang aja
already
deh.
join us.
Ya, Assalamualaikum warahmatullahi wabarakatuh. I'm sorry, this
Waalaikumsalam
problem
warahmatullahi
technique. Good afternoon, everyone.
Good
My name is Dr.
afternoon.
Tini. I am lecturer of Health Polytechnic of East Kalimantan. It's truly an honor to be here today as one of the speakers in this insightful webinar on digital transformation for global health. First, let me express my appreciation to the whole Polytechnic of East Kalimantan for this opportunity and to all participants who have joined us from various places. The rapid advancement of digital technology has brought tremendous change in the way we deliver, manage, and access healthcare. Today, I'd like to share some thoughts and experience on how digital innovation can improve health services and empower communities toward a healthier future, especially for diabetic food prevention. And now, my topic is community empowerment on diabetic food prevention in the digital era. Yeah, as we know, diabetes is of the major health challenges worldwide. Indonesia has the fifth highest number of adults with diabetes in the world. That is data from IDF. Uh, 2024, and diabetic foot is one of its most serious complications. It's estimated 8 until 15% from diabetes population. Many patients lose their quality of life because of late detection, poor food care practice, and limited health literacy. Therefore, community empowerment plays a crucial role in improving awareness, early prevention, and self-care behavior. In the digital era, we now have new tools to reach, educate, and engage the community more effective. Okay, next. Okay, let's begin with the basics. Um, we talk about diabetes mellitus. Diabetes mellitus is a chronic condition uh, that occurs when the body cannot produce enough insulin or cannot use it effectively. As a result, blood sugar levels become too high, and which over time can damage many parts of the body, include the eyes, kidney, nerves, heart, and feet. And one of the most serious and preventable complication of diabetes is diabetic foot. This happens due to nerve damage, it's mean neuropathy, and poor blood circulation or ischemia, which make the feet more vulnerable to injuries and infection. Many patients do not feel pain when they have small wound or blister. This wound can worsen, become infected, and if untreated, may even lead to amputation. Um, there are several early signs we need to pay attention to numbness in the feet and frequently feet pain when resting, feet cold and experience decreased pulse, and can happen dry, cracked skin, and thickening, and brittle and thickening nails, and change in the shape of the feet. The main causes and risk factor of diabetic foot are neuropathy, obesity, smoke, history wound, poor blood sugar control, irregular foot care, and using inappropriate footwear. When these factors combine, the risk of wound increases and healing becomes more difficult. Yeah, but the good news, the diabetic foot is that most can actually be prevented through awareness, early detection, and consistent self-care for blood sugar control. And this, where community empowerment becomes very important for diabetic food prevention. Okay, we talk about community empowerment. So community empowerment means giving people the knowledge, confidence, and tools to take control of their own health instead of relying only on hospital or doctors. We encourage communities like patient, family, and local health volunteers or cadres. That means to become active agent in health prevention. The goals empower community can help each other recognize early warning sign, share practical food care routine, and support member living with diabetes or make a peer group because peer-to-peer diabetes patient approach is often more effective and sustainable, especially in rural or low resources area. And now, in the digital era, we have new opportunities to strengthen this empowerment efforts. Digital transformation is change how we communicate, how we learn, and access services. For example, we use social media like Zoom, like YouTube, because social media can be used to spread how message quickly. Use a short video on TikTok, yeah, or Instagram, showing how to perform daily food care. Uh, Mobile health apps can remind a patient to check their blood sugar and inspect their feet every day. Uh, so, online community such as diabetes patient forum can help improve their knowledge anytime and anywhere for patient diabetes mellitus. Exactly, um, empowerment strategy can use telemedicine, allows people to consult doctors remotely, especially those who live far from healthcare facilities. Let me share a simple example. In some communities, a local health center have created WhatsApp group for people with diabetes. Every morning, a reminder message is sent, something like, good morning, don't forget to check your feed today. Now, so members also share photo of healthy meals or experience in managing food wounds safely at home. It might sound simple, yeah, but this kind of digital community support can make a real difference. And that's our goals because it builds awareness, motivation, and connection. That is three key elements in successful health behavior change for reduced case of diabetic foot ulcer and amputation. So, what is the role of health worker? Health worker have roles of providing education through digital platform, developing educational content, and do cross-sector collaboration. Cost, yeah, digital transformation also comes with challenge. Not everyone has equal access to the internet or smartphones. We must ensure that digital health initiatives remain inclusive, easy to use, and culturally appropriate. Another challenge is maintaining credibility and privacy. How information shared online should come from trusted sources in order not to hoax. And other challenge lack of easy to understand local content. Okay, everyone, as we move forward in the digital era, it's clear that technology is not just change healthcare. Technology is not a substitute for human caring, but a means to expand that caring. It's transforming lives. However, the success of digital transformation depends not only on innovation, but also on collaboration, inclusivity, and a strong commitment to equity. I hope today's discussion has given us valuable insight and inspiring, to continue improving our health system through digital means. Thank you very much for your attention. I hope this session inspire us all to take part in promoting digital health and community empowerment, especially for diabetic food prevention. I'd be happy to take your question and hear your thoughts. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much,
Silakan,
Ms. Tini,
moderator.
for your presentation. What a great conclusion, yeah. Technology is not substitute human caring, but a means to expand the caring. Yeah, that's really great. Okay, this time we move to the question and answer session. Please, all participants, if you have any question, you can raise
Mr. Lee.
hand. Open
I'm
your
sorry, Miss Lia, I'm
camera
not here.
and your microphone, please.
Your sound. What is this?
Okay, we're still waiting for the question. Please open your camera if you have any question. Don't forget to introduce yourself. Okay.
Thank you for
We
the
already have.
moderator. First of all, let me introduce myself. My name is Diabetic Sandi. And good afternoon, Ms. Tini. I would like to ask, how can this digital transformation that you have mentioned in your presentation can make a diabetic foods prevention more sustainable in this era?
Okay, thank you very much, Dava, for your question. I will try to answer your question. That is a good question. Digital transformation to make diabetic food prevention more sustainable. Yeah. How can that is? Digital transformation enable continuous education and monitoring without requiring constant physical meetings, because it helps create a network of informed individuals who can share, remind, and support each other. That is, can be sustaining prevention efforts over time. Yeah. Thank you very much, Dapa. This is my answer. You can you can understand that?
Is it clear, Mr. Dava? Okay. We move. Maybe, is there any question again for all participants? We still have one opportunity. Okay, please.
Excuse me, before I ask my question, please allow me to introduce myself. My name is Kusno Fatima, a medical laboratorium technology student from Poltekkes, Kemenkes, Kalimantan Timur. With your permission, I would like to ask a question. What strategies can be used to aid
your generation in diabetic food prevention programs?
Yeah, okay. Thank you very much, Husnul, for TLM. That is good question because you are younger, yeah, younger generation, Gen Z, yeah, and you have apa namanya, you have to help for the diabetic food prevention. Yeah. The strategies, yeah, to inject a younger generation in diabetic prevention program, you can use digital platforms they're familiar with, like Instagram. So can use Facebook maybe, TikTok, yeah, or YouTube, and you can make with creative visual content. You can make two short video, yeah, a challenge or infographics can make whole message um, more relatable and appealing to younger audience. So that's can to make for younger generation for prevent, yeah, happen to diabetes mellitus, because diabetes mellitus can happen it for young, not only all, but the child uh, can happen to apa namanya diabetes mellitus, ya. Thank you very much. Your question, Husnul, it's good question. Can you understand with I mean?
Is it clear, Mrs. Null? Okay. Okay, thank you very much for all the question. And yeah, this is the last for our session. Thank you very much, Ms. Tini, for such an informative presenting about food diabetic. In this digital era, we hope that we can use our technology to access so many information about diabetes, and we can prevent it, especially for diabetic food. We can access very informative information in the internet about diabetes, how to prevent it, how to manage it, and we will use the telehealth to remind our eating, our diet, and how we can improve our health worker as a health worker to be the educators for diabetes. Okay, this is the last for our session, and I would like to say thank you to all of our speakers today and all participants for active participating in this international conference. Okay, I will return it to the Master of Ceremony.
Thank you very much, Ms. Dia.
Oh yeah, before that, I'm really sorry that, yeah, we will give the virtual certificate before for Ms. Tini as second speaker. Yeah, please, Ms. Tini, this is our virtual certificate, and thank you very much, Ms. Tini, once again for your presentation today. Okay, I will return it to the Master of Ceremony.
Okay, thank you to Ms. Dia that leading the last session for this seminar. Okay, ladies and gentlemen, as we come to the end of today's international seminar on digital transformation for global health, we would like to extend our deepest gratitude to all the distinguished speakers, the honorable guests, and the participants who have joined and contribute for this event. May the insight and discussion shared today inspired us to continue advancing innovation and collaboration in global health through digital transformation. On behalf of the organizing committee, we sincerely thank you for your participation and attention through the program. We hope to see you again in our future academic and international event hosted by Poltekkes Kemenkes Kalimantan Timur. And thank you, stay safe, and have a wonderful day ahead. Goodbye, everyone. Billahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.